Uh, Second part of this today's PG update is a case discussion on oral malignancy with difficult airway, presented by Dr. Anu Susan Abraham, who is a PG resident, Amrita Institute of Medical Sciences, Cochin. The examiners for this case presentation, external examiner, Dr. R.P. Gadu, who is the professor and HOD of anesthesia at D.Y. Patil Medical College, Mumbai. Dr. Gadu, I am really happy and honored to welcome you because you always like to come and enjoy the greenery of Kerala. We hope we will see you in person when the situation improves. I take this opportunity to welcome you, sir, Dr. Gadu. The internal examiner for today's presentation is Dr. Sunil Rajan, who is a professor of anesthesia at Amrita Institute of Medical Sciences, Cochin. He is our own member, an excellent teacher. Sir, I welcome you to this meeting. We have Dr. Venkatagiri KM, who is the President-elect ISA National, who is coordinator for this meeting and encouraged us to organize all such academic activities. Dr. Giri, I welcome you.
Thank you.
Today's moderators for the academic session, Dr. Rajesh MC, who is the scientific chairman of ISA Kerala State Chapter, and Dr. Vijesh Ganuwal, who is the governing council member of ISA Kerala State Chapter. I welcome Dr. Rajesh and Dr. Vijesh Venugopal to this meeting. I welcome our own secretary, Dr. Biril Isaac Matthew, who is working hard behind organizing all such excellent academic program. I welcome all the senior members of ISA, senior officials, teachers, and students to this meeting. Thank you all. I request Dr. Giri Venkatagiri for his opening remarks. Dr. Giri, please.
Good evening, President Dr. Nazar, Secretary Binil, faculty's good friend and faculty, Dr. Gedu, and all faculties and senior teachers and all. Happy to be participating in this event, and it is going strongly week by week with more and more faculties and teachers participating, and more and more PGs, not only from Kerala, from outside also participating. A very important topic today that we have the statistics which many people find it difficult to get from anywhere, and we have good faculty for that, Dr. Rakesh Garg and Sudesh Kannan. And as examiner, we have our favorite Dr. Gedu. So welcome them all, and I wish all the best, and we will go more strong in the coming days, and it will be more useful for PGs from all around India, not only from Kerala. All the best to everyone, all the students.
Thank you, Giri. We will move on to the academic part. I request Dr. Rajesh MC and Dr. Vijesh Ganuwal to take over the academic activities.
Good evening, everyone. Today we have two important sessions. One is mainly for the theory part, and the second is for, as you know, it's a practical part, and you are most likely to get a case on difficult airway. So you have oral malignancy plus difficult airway. And along with this, in the initial part, we have statistics. And in every question paper, whether it is DNB or MD, you are likely to get a statistics part, which is a less covered portion in the theory discussion in the our usual academics. So we are fortunate to have two excellent faculties, Dr. Rakesh Garg and Dr. Sudesh Kannan. And they have done a lot of research and a lot of publications on the subjects. Not only on statistics, Rakesh has done a lot of work in the formulating all India difficult airway guidelines also. So we can utilize his presence in the second part also. And so over to Dr. Rakesh and Dr. Sudesh. And this will be discussed in 3 sessions actually. So we'll start with the first session, statistics part 1. Over to Dr. Rakesh and Dr. Sudesh.
Thank you so much, sir. Thank you, the ISA Kerala State Chapter. Special thanks to Dr. Venkatagiri, who always gives us an opportunity to interact with you all, sharing the knowledge and learning from each other. Thanks to Dr. Nazar and Dr. Matthew also for running such a successful academic program for long. And a special thanks to Dr. Rajesh as well and Dr. Venugopal for taking academic activities for the benefit of all of us. So now today we'll be talking in series of 3 about the various statistical aspect. We'll keep it on the basic aspect of understanding the statistics. So we're not going to very sophisticated advanced version, but when we say the understanding of statistics, it is equally important to understand basics, not just for the purpose of doing research, but also for the purpose of uh, understanding the published literature, and that is very, very important. So we'll be touching in today's part 1 about the method section, and we'll be discussing about the variables, the sample size calculations, and how to choose various variables, which will be taken subsequently by Dr. Sudesh Kannan. So when we talk of method section, now this is one of the very important aspect of conducting any study or reading and interpreting any published study. Because if the method is good, if it is robust, it is repeatable, then only we can rely upon the results part of it. If there is a lacuna here, it has not been done well, obviously the results will not be acceptable to the community. And if results are not acceptable, the discussion does not carry any meaning. So we need to spend some time when we plan our research on the method section. And this is the key section when somebody of you send an article for publication. It's one of the commonest reason for the rejection of these articles. I bring greetings from my institute where I work at the Cancer Center of All India Institute of Medical Sciences. Now, methodology of any study, whether you are writing a protocol or submitting it for the purpose of publication, it should be a detailed strategy that how the objectives or the hypothesis which you have planned, they could be achieved. And it should be replicable. Replicable can be done only when it has a complete detail. And thus it assures that the hypothesis will be proved or disproved using the right tools that we'll be using again in the method section. So it has 2 components basically. One is the strategy part of it, and one is the tools part of it. So both has to be in detail so that the understanding of the method becomes very crystal clear, and hence whatever the results comes out, they appears to be sensible, they appears to be acceptable because the method section is strong. Now, the first aspect is when we set up the hypothesis or objective, at times we think the objective should be many, it should be in multiples, they could be primary or secondary objectives. But remember, they should be kept to minimum, because when you do a study, you cannot target multiple number of outcomes, multiple number of objectives. So it should be very clear that what are you looking from your method section. Having said that, if you keep your objectives, say 3 primary objectives, 3 secondary objectives, your method section will be in such an elaborate manner that they will contradict each other. So choose your objectives very, very cautiously based on your experience, based on your teacher's experience, because they will guide you to understand, or a person who has expertise in that field. And they should be specific, measurable, attainable, relevant, and time frame. And these are the smart criteria when you plan for objective. And once these objectives are planned, it will help you to understand how the things can be done. Now, let me show you this statement. If I put my objective as to determine the impact of pregabalin in patients undergoing abdominal surgery. So this is my objective. But if I ask the participants who are listening to me, do you think this objective is very precise? Does it give me something good meaning that I can attain out of my methodology? I would say no, this is imprecise. What I need to do is I need to make it very specific. And this is what I want. When I said it should be replicable, it should be detailed, this is what the difference is. This is what at times we can write, which is not acceptable. But this is what we need to write. This we need to expand. So we can just mention to determine the analgesic efficacy of single dose of oral pregabalin as an adjuvant to, as compared to placebo administered 2 hours prior to surgery in adult patients undergoing laparoscopic abdominal surgery under general anesthesia. So this is how you can elaborate your objectives or hypothesis, and same would be applicable for the for your research question also. So this is what precision is required. Precision does not mean that you became a little miser in the words. In method section, you should be open-hearted with your words. in discussion, you should be miser in the sense that you should be very focused there. Now, this will translate into when you write your method section, once your objective is clear, you should translate into a meaningful endpoint, right? For example, we were looking for reduction in the opiate dose in the post-operative period, or reduction in the numerical rating scale by a scale of 2 or 3, whatever you decide. So it should have some clinical meaningful, and it should be sensitive to the effect of treatment. For example, if you are looking for the beneficial effect of pregabalin as an adjuvant, we should be saying that yes, if there is a reduction in the consumption of morphine post-operatively by 25% as compared to control group, so this has some clinical meaningful, it has some sensitivity to the primary outcome for which we are using. And this should influence the physician decision, because when we say, for example, say in cancer surgery, when we want to have, say, opiate sparing benefit effect of a drug, then this will be having impact on the physician decision. And this also determines the sample size, which will be discussed subsequently by Dr. Shabish. Now, when you plan a research question, always remember, so once we said objectives, when we said the outcome, and the other important component that comes for the detailed methodology section is the research question. So always try to incorporate this mnemonic of final: feasibility, interesting, novel, ethical, relevant. Many of you, or even including me, when initially I used to submit paper, I used to get a rejection saying that there is nothing novelty into it, there is nothing interesting into it. So this has to be very clear, and this is based on an extensive review of literature or a clinical issues which will help you to understand that what are the novelty of your study, and anything that you do should be ethical and clinically relevant. And this final criteria should be translated into the PICOT. So any research question, now this is important, this PICOT word, many people will be using at the stage of title, they should be using at hypothesis, people will be using at research question, people will be using at outcome monitors. So this PICOT is an important aspect because this is the key principle of deciding your method section. So whenever you write a statement of objective of a research question, this should have a study population, define a study population, adult patient, pediatric patient, obstetric patient, whatever. Intervention to be tested, as I mentioned, 75 milligram of oral pregabalin. It should be very specific, right? It could be therapy, it could be any medication, it could be even test. So it should be very specific, but focused. Control arm, against which? If I use two drugs, both are new, which is better than which, I do not know. So I have to compare with some, either a gold standard or a standard of care. So that should be your control arm intervention. Outcome, I already mentioned, it should be very precise, specific, and objectively defined. And the timing of measurement. I cannot say that the post-operative reduction in analgesic requirement. It should be very specific in how much duration. First 24 hours, first 8 hours. So this should be very, very clear at what point of time your outcome measurement is going to be done. Now, the second aspect which method section should comprise of is the study design. This is an important aspect because the study design is based on ethics, logistic, your economics, or scientific thoroughness, or a review of literature. So you need to plan a study which is important. For example, if you want to do a study which is a little rare, for example, you want to look for some inflammatory markers in patients of say thalassemia with COVID. So it is a very rare. So you cannot have a randomized controlled trial because you will not be getting many patients. So maybe a case control study would be better for such type of study. So this means based on your objective, your study design should ensure the validity of results with due consideration of bias, confounding, and generalizability. So these are the three keywords which I have used here: bias, confounding, and generalizability. So based on this, you can look for a study. So when we say the type of studies or the research which are published, it could be primary or secondary. Primary, basic research, clinical trials, or epidemiological trials. Most of the time, we are more concentrated on clinical trials, which are experimental studies. But at times, some of us may be interested for the basic research, or maybe at times the observational studies, or sometimes in the epidemiological part also. For example, a follow-up of pain patients, follow-up of cancer patients in a cohort, that what is the incidence of quality of life, the quality of life as such in a cohort of patients which are coming with advanced cancers or they are inoperable. So, but we'll be concentrating in next 3 series more on the clinical trials because it is 90% of time we'll be doing as a postgraduate dissertation for this. So we'll be focusing on it. The secondary research is also at times done, which is important for understanding the various published literature. It could be a systematic review and meta-analysis, which is the most acceptable one. But some experts can also give us a narrative review because of their experience and expertise. They can put their own experience into it to come up with a narrative review, which is always many times useful from the academic point of view. But do remember, when we try to, I said in the beginning that the clinical studies are for the clinical translational value, or it's the change in the physician's decision. So this is what the hierarchy of level of evidence. Usually, we do not expect the physician decisions to be changed based on case series or case reports or such similar comments from the experts or editorials. The whole profile of management may not be changed. But in case if we have something very robust, which has a clinical translation value from a meta-analysis of multiply published randomized controlled trial, now this is where we can choose to change our clinical practice because the studies from various places by various experts has been merged into one with some meaningful outcome. And this is what the systematic review and meta-analysis is. And if it depicts that pregabalin is a good adjuvant drug to reduce the requirement of opiate analgesics in the perioperative period, then we can rely on it and start using the pregabalin as a part of your multimodal analgesic management. But if a meta-analysis says does not have any effect, then we should be cautious of not using it. Though with my personal experience or with number of single case reports or case series may have shown its beneficial effect. So that's how we can decide the usability of various research publications. The other component of method section must contain the study area because many of us may be working at a tertiary care referral center. And many of us must be working at district hospitals, and both of us are giving anesthesia. Both of us may be getting a similar type of surgical procedures. But when we say a district hospital versus a tertiary care center, the selection of population is different. Working at a tertiary care center will be getting more of an ASA3 patient because we have the facility to get them done. But a district hospital, uncontrolled hypertensive with CAD, probably they do not have a facility, so they may not be doing it. So this means the selection of patient cohort or patient profile would depend upon the study area. And that's why we should be mentioning always that this study has been done at this level of hospital in this setting. Study period should also always mention because we know that this medical science is changing very fast. We all have seen during the COVID in the last 1 year, we started with certain drugs. We found that it was not usable, and same science is changing for many aspects. All of us know the crystalloids versus colloid fight is always on. Sometimes something is better, sometimes something is better. So this means if we define that this study was done during this period, it will be useful to understand that this was the standard of care during this period when the study was done, and hence it will be useful. The selection of study subjects and participants is very, very important. You should be very clear about the inclusion and exclusion criteria. Now, one of the commonest thing that we see during the protocol submission and during the publication process, one thing needs to be remembered that only those patients can be excluded from your study which has been included. I will give an example. For example, if you have included patients of 18 to 60 years into a study, you can only exclude patients into this age group. Sometimes we see in the inclusion criteria that the patient from 18 to 60 years will be included in the study, but exclusion says patient less than 18 years were excluded. So this is a little misnomer type, you can say. So only those patient population that you have included in your study, from those you can exclude some patients if they have some interaction, some influence on the primary outcome. For example, if you're looking for the bleeding issues, right, in the perioperative period, probably patients with decompensated liver failure or liver failure patients should be excluded because they will be affected your coagulation profile. So this is how you need to choose for. But remember, if you see the studies which were published around 10 or 15 years back, there used to be a lot of exclusion criteria. Patient with hypertension, patient with diabetes, patient with CAD, patient with this were excluded. Now, In a clinical practice, say for example, a tertiary care hospital, more than 50% of patients will be hypertensive. So if you exclude all those patients, your research may not be useful to the clinician. So you have to follow a pragmatic approach nowadays. So try to exclude only those patients from your study which can influence directly the outcome of your study, not all disease, not all conditions which are not related to the outcome parameter. So this is one of the important aspects for inclusion and exclusion criteria. Also think of planning for the purpose of data collection, compilation, entry, data cleaning. This is an important aspect because when you do a statistics, this is important. If your entry of data that you collect, how are you going to collect? Do you have to have a case record form, which usually has its own norms how to make a case record form? You can just go online, which all information should be there. Sometimes we mention patients, say especially when a pediatric age group, sometimes we say if the patient is 6 months, 15 days old, sometimes 1 year, sometimes 6.5 years. So this difference into the recording section of days, months, and years will be a big issue when you do a statistical analysis. So all data collection should be uniform, should be as according to your case record form, and it should be methodical. Also check that during the entry of data from the file to case record form and from case record form to an actual sheet should be doubly checked, because sometimes while typing a blood pressure of 120, you can write 1200. So when you just get an average blood pressure, it will be much higher. So that's why you should check your data correctly, because even a single reading missing or miswritten can alter your outcome. So be careful about those things. Now, this is again an important slide, which at times we miss during dissertations and submissions. The tools, terminologies, orientation, training is important. Why I said tools and terminology? Because, for example, say you want to look for the hemodynamic response of a video laryngoscope versus a conventional laryngoscopy. Now, hemodynamic response will be respiratory, will be your blood pressure. Now, blood pressure could be measured by various modalities. It could be an invasive blood pressure monitor using arterial blood pressure. It could be through your non-invasive blood pressure automated monitor, or it could be a manual also. So now when you use 3 different type of monitors, the BP recording will be different. So you should define that the blood pressure will be measured using this tool. So it should be specific so that each patient should have same modality of recording the outcome parameters. So that is very, very important. And then you can mention them in performance so that the collection remains uniform. So it has to be very, very clear. The other important aspect is the measurements, whatever outcome measurements, whether you're looking for the pain severity scores, whether you are looking for the blood pressures, whether you're looking for patient quality of life, you should be very clear at what point of time, how, when, and where. So these 3, you should always question whatever you mention in the outcome parameters. So always define your clinical examination, the gadgets procedure. You always mention which test, for example, say blood sugar monitoring. Blood sugar monitoring can be done from serum sample. It can be done from capillary blood. Both will have different reading. Venous, arterial, and capillary, all 3 will have different readings. So you need to mention that the blood sugar will be monitored using a serum sample. So that is what you need to define, because the uniformity of data collection should be same for all the patients that you are looking for. At times, like in COVID also, or sometimes when you are doing a qualitative study, you require a questionnaire. Now, these questionnaires either must be standardized or validated, which are already published. In case if you think you're doing something novel which is not present, you should know how to validate a questionnaire before you start using them. So it has a proper process where you validate your questionnaire before you start applying into your study, and then only starts using them in case if they are not available with you. And to take your ethical clearance from appropriate bodies, which is very, very essential. The next important aspect is sampling techniques. Now, at times, depending upon the type of study, you need to select some population. You cannot do all patients. For example, if I want to look for the quality of life in advanced cancer patients coming to my pain clinic, so this means probably I will not be doing all patients who are coming, because I'm getting say 50 patients in my OPD, so I'll not be covering everything. So I need to sample some of them, right? So this means they're selecting a group of people from a larger population, which is called sampling. And then this study outcome is extrapolated to outcome. So this means if your sample is not appropriate, it is biased, you cannot extrapolate to others. So this is what is important, and that's why the sampling should be such that it gives equal chance to every observation unit to be selected for study in a sample. So no observation should have any zero probability of getting entry into a study. So this is very, very important to avoid this selection bias. Once a selection bias creep into a study, the results, the outcomes will be unacceptable. So very, very clear about those sampling. So this sampling can be probability, which is the gold standard, or at times it could be non-probability. Non-probability are these things which we use sometimes for rare disease. So I will say that any patient between 12 to 1 who comes into my OPD will be recruited, right? So this is not a standard of care. This is not an acceptable thing, but sometimes we use this type of sampling for rare disease. For example, you want to look for those patients who are having HIV, who are having some rare disease, like say hemoglobinopathies. So you can always say that if any of your colleague, if you know, because they will be attending special clinics who have hemoglobinopathy, they can come and get recruited into a study. So in those rarer disease or small population or special population or a special condition, you can use this type of sampling. But majority of clinical trial, probability sampling should be done because it gives you more generalizability. The chances or the bias is less if you use this type of sampling. And these are the 4 ways of doing it: simple random, systematic, stratified, cluster. Now, most commonly in our clinical practice of anesthesia and pain, and even for patients in follow-up in the post-operative period, we use this simple random sampling. But when we talk of the critical care related subjects, we try to use at times systematic sample or stratified random sample for patients in those focus group. I'll come a little later. So when you say this sampling techniques, depending upon the outcome parameter, for example, say when I say the stratified random sample, for example, if you think outcome parameter is affected by age, right? For example, say anxiety. Anxiety, young patients have little more anxious. So if you think, if your group is having from 18 to 60 years and the outcome pain is affected by the age, then you need to have stratified. So you will be describing your sample from 18 to 40 years and 40 to 60 years. And then there are 2 stratified groups that you have, and then you randomize into 2 groups. So in this way, both the people or both the group will have equal amount of younger and older population. So this is what I have summarized till now. You look for your target population, select your sample, select a study population from it, and then a study sample, and then finally you randomize into your groups. Now, when we say randomization, now all these groups, whether it's a 2-group study or a 3-group study, they cannot be absolutely for using a new technique on a new drug. Of these, one group has to be a control group. And this control group, why do we need it? Because you want to prove that some new drug or new technique or new intervention or new test is better or inferior or comparable to a standard of care. So this control group could be either a standard of care or it could be a gold standard, right? And also at times, when we say standard of care or control group, because at times a placebo effect could be seen in these patients, right? For example, say when you are following up your pain patients, when you're following up your post-operative patients, sometimes presence of yourself can influence the pain rating. Looking at you, sometimes patient may say that they are feeling more pain to get more attention, or they can say that they don't have a pain because they are afraid of scoring in front of you. So just avoiding this placebo effect or the influence of the observers to monitor those outcome parameters, you need to have control so that it is balanced in the both situation. Now, sometimes placebo should not be used for, especially for example, say in pain studies, intervention studies. You cannot say that I will insert a catheter into a paravertebral space. I will not give any drug from it, but I will remove it after 48 hours. So this is a little unethical because giving an intervention and not using it for pain management becomes unethical. Similarly, you cannot say that in one drug I will give analgesia, another will I'll not give analgesia and monitor for the NRS scale and look for the effect of certain adjuvant drugs. So placebo may not be possible or not ethical in certain groups, like for example, say low dose group or group treated with standard current therapy or gold standard. So those situations, you try to have a standard of care rather than no care. So no care is unethical. Don't try to use as a control group. Use the standard of care or the standard gold standard, or maybe if you want to do a dose study, to use them. The next aspect is randomization. Now, randomization, the basic principle is to enable a fair and unbiased division of the population in two groups in a random fashion, and that is what needs to be done. How it can be done? It is being allocated is unpredictable to all who are involved in the study. Earlier, we used to say the investigator and the patient. Now we need to say everybody, even the statistical people, even the observer, even the caregiver, even the hospital, other staff. Everybody should be unaware of the allocation of a particular patient to a particular group. And this will help to know about certain factors. Now, when I said initially about the inclusion, exclusion parameters, so those are the known parameters. But for example, the pain, we will usually avoid looking for the anxiety factors, the other things. So there are many unknown factors which can influence your outcome. So to have the equal distribution of both known and unknown, this randomization is very, very important. And how can you do it? You can do it by tossing coin, kit-based, year of birth. So this used to be done, but these are not the correct methods because they can influence your randomization technique. The most commonly that we use is the random number table, or you can use now computerized software for generation of these random numbers. Now, this is a simple randomization using random number table. This is table which is available online also, in books also, you can use them. And based on this, for example, you want to compare two drugs, treatment A and treatment B, 16 patients are there. You go to this table, in any direction, pick 16 numbers. These are the 16 numbers. Now replace 0 to 4 by A and 5 to 9 by B, and replace the digits to the alphabets, and you get a sequence. Now, restricted randomization is done where you want to the equal distribution of the various data at any point of time in a study. Then you can use the permuted block randomization. Here you use a combination of two. The group's allotment is done in combination of two. For example, your sample size is 40, block size is 2. Then the combinations you can choose as A, B, B, A. And the same thing where earlier I mentioned you replace 0 to 4 by A. Here you will replace with A, B, and B, A. So at any point of time, you will have equal number of interventions or assignments or assign of a particular intervention equally in both the groups. The stratified randomization, as I mentioned, for example, patients of different age, or if you think the gender influences, and if the gender differences is there in the two groups, then you can do a stratified randomization where one group is separately randomized and the other group is separately randomized, so that finally both the groups of study are equally distributed with the parameters that would have influenced your outcomes. So this is what can be done. Similarly, for the age factor, 26 to 45, 46 to 65, and more than 65, you can randomize separately to them. So for stratified randomization, you need to think which parameters can influence the outcome, identify them, and then those 1 or 2 or 3 parameters, you can separately randomize them so that each group has those parameters equally distributed. But randomization is not the everything. Even if you know the randomized group, the bias can happen, because if you know the group, you may not include the patient to a study on that particular day, and that can lead to selection bias. So that is what allocation concealment is, where the person who is recruiting the patient finally into a study does not know that in which group he is going to do once the patient is being recruited. Once the patient has entered into a study, then only he will be aware that which study group patient has gone in, and this is what is allocation concealment. So proper allocation concealment shares knowledge of forthcoming assignments, where random source generation prevents correct anticipation of future assignments. So this is what the difference is. And the person who generates and doing the concealment of the sequence should be an independent person. They should not be part of doing the interventions for this patient. The techniques available, most commonly we use sequentially numbered opaque sealed envelopes. So you generate a random number sequence. Each number is written on a piece of paper. You put them into an opaque envelope, you seal them, and then you sequentially number those envelopes and open them in sequence. So this is the commonest one. But for multicentric trial, the telephonically or best-based randomization is also required. Next comes the blinding. Blinding is important because blinding can lead to issues of creating bias into a study. Earlier, we used to use the terminology like single blind, double, and triple blind. Though these terminologies are not being used right now. What is we use is blind as many as individuals as possible in the trial, and this should be descriptive into your study. Participants, practitioner, data collectors, statistician, data analyst, everybody should be blinded. And blinding may often be possible using simple techniques, right? So you can conceal the incisions, you can have similar drugs, you can remove the wrappers of the drugs, use independent outcome assessor who are not involved into your interventions. In case if blinding is not possible, for example, you want to compare outcomes of a laparoscopic versus open surgery. So you cannot blind those because this will be quite obvious. So you can standardize the treatment or the observations to some in such an objective way so that the bias cannot creep into. So this is what is very important where the blinding is not possible. Otherwise, try to blind as many as people into a study to the assigned allocation of the group. So remember, blinding is not as same as allocation concealment. Allocation concealment is prior to your study recruitment, and blinding is once the intervention has been started. So these are two terms, and both must be descriptively described into your method section. The last aspect which I'll be covering is the bias and confounders. When you do any study, any bias can creep into your study, which can influence the outcome based on your exposure. So that is what is bias is. And even at the time of even a presence of a clinical researcher can affect the behavior of the subjects. So this is called Hawthorne effect. So there are many types of bias that needs to be taken care of. For example, selection bias, imbalance in the baseline characteristic, loss to follow-up. So when you plan a study, you should be knowing that this number of patient population may die or they will lost to be follow-up in a follow-up studies. So this type of selection bias must be taken into consideration, and how you will try to avoid this bias needs to be mentioned. Similarly, measurement bias. I mentioned earlier that whatever equipment you are using should be validated, whether it's a questionnaire, whether it's a BP apparatus, anything. So it should not be changed for each patient. It should be uniform. Recall bias is one of the important where you based like for example quality of life or the experience of patient of a hospital stay. So this time sometimes patient can have recall bias, so we can give them a diary or we can give them something to record so that this type of bias does not happen. Observer bias, BP measurements, I gave an example, so be careful, use one. At times you can give them a training that this is the correct way of measuring this outcome in these patients. And similarly, we look for the parameters which have a confounding. For example, we want to have a characteristic under study and we want to follow up disease. But there may be factor which can influence both the exposure and the outcome. And this is what is confounder is, and that needs to be taken care of. The last aspect is the validity issues. So when I say you have done a sampling of a study and you want that your study should be applicable into your study group as well as to the population in whole as such. So there are two aspects of it, internal validity and external validity. So this means internal validity means the extent to which the extraneous variables have been controlled by the researcher. That's why your method section should be in such a detail that everything is very objective, uniform, and replicable. And external validity means the extent to which the findings can be applied to individuals and setting beyond those who has been studied. So you can apply to other patient population also. So that's why your sampling should be appropriate, your randomization should be appropriate so that the bias is not creep into a study so that you can apply your patient population outside. Now, this is the last slide I mentioned. You can get some more method inputs or the components of the method section depending upon your type of study. For example, consort is for RCTs, strobe is for observational studies, and they should be a part of your things. So well-planned and well-designed study is the important aspect for a good study, for its good publication and having a clinical translation value. So thank you so much for the patience hearing, and over to the organizers for next session.
Thank you, Dr. Rakesh. And do you want to answer the questions in the chat box? Is there any questions? Or we'll go to Dr. Sudhish's talk, and finally we will clear the doubts in the chat box. Yeah. Okay, we'll go to Dr. Sudhish Kannan. Dr. Sudhish.
Good evening, sir. Good evening, all dignitaries of ISA Kerala, Venkatagiri sir, E.K. Nasser sir, Binil sir, and Rajesh sir, and Vijay sir. Thank you so much for the opportunity given to me. Hello. Thank you for the opportunity given to me on this August platform, sir. In continuation with the statistics class methodology part, what Dr. Rakesh Gar described till now, I'll be taking over the reins from him, and I'll be presenting regarding the sample size estimation. So to start, before starting with the sample size estimation, one thing what I want to make it clear here is whatever Dr. Rakesh discussed about sampling. So you already have heard a word about sampling in the previous lecture. So that sampling is not same as the sample size estimation. They are totally different terminologies, and they are totally different. So I request the listeners not to get confused between these two. Okay. So sample size estimation is basically once you decide from which the way of sampling, in that how many subjects you are supposed to pick up is what is meant by calculation of a sample size. So that is what I'm going to deal with it in the next 20 minutes or so. So there I'll be touching upon a few more topics which are of interest from the exam point of view. One is the hypothesis, and second thing is alpha and beta errors and power of study. And sample size estimation itself can be a question for 10 marks. So I hope I'll be able to touch upon all the points and clear your doubts maximum possible. So we just start off with an example. This is one basically an obstetric article where they have tried to compare the effectiveness ormeloxifene and norethistone in perimenopausal DUB treatment. So in their methods and material methods, they simply mentioned that study population comprised of 60 perimenopausal women with complaints of excessive bleeding. I hope I am audible. Sir, am I audible?
Yeah, you're audible.
Sir, should I increase my volume? Is it okay, sir?
It's okay. This is okay.
Yeah, right, sir. Thank you. Thank you so much. So the study population comprised of 60 perimenopausal women with complaints of excessive bleeding. Do you think is this the right way of presenting the sample size? This one? It's a very, very primitive way of presenting the sample size, the recruitment for the study. In the next 20 minutes or so, we'll be trying to understand the proper way of presenting the sample size. One is how to calculate, and next how to write it properly in a dissertation or in a article. So to start with the basic need, like why do we need to calculate sample size? So that's a basic requirement what you need to understand. Sample size calculations are required to define at what number of subjects it becomes quite unlikely that adding more subjects will change the conclusion. So what I mean to say is, it's a minimum number of people required to produce a meaningful conclusion which cannot be changed by adding more and more subjects. So in simple words, the minimum number of people. Now, why you want to have this minimum number of people? Why can't we take an arbitrary number or arbitrary sample size? So there are two possibilities if you don't calculate the sample size. One is either you can recruit less number of patients, or you end up recruiting more number of patients than what is required. Now, what are the problems of undersampling or recruiting less number of patients? One is it might not achieve the required statistical significance, though it exists many times. And second thing, the results may not be consistent when the trial is repeated multiple times. And third and most important thing is, many times it questions the validity of research. So these are the disadvantages of undersampling. Whereas at the same time, you cannot go on recruiting more number of patients just because they come to your OPD or they come to your OT. It is because many times, if you recruit more number of patients than what is required for the study, there is always a possibility that even a small difference between though the clinical difference between the two groups exists is very small, it may start showing statistical significance even it's not even if the significance is not actually existing. For example, let us say you are supposed to recruit about 12 patients in each group. When you're trying to find a difference between the duration of analysis we have between two different types, drug A and drug B. And as per sample size estimation, you end up calculating the sample size of 12 in each group. However, because you are getting around 100 patients per day, 100 patients per month in your OT, you try to recruit 30 each. So even if the difference between the two groups with respect to duration of analysis is only around, let us say 20 or 30 minutes, that will show a statistical significance with the p-value of less than 0.05, which might influence your observations and your outcome when you write it in the article. So that is a major issue with using a larger sample size. And most importantly, you are unnecessarily exposing the patient population to a new drug, especially when you're doing a trial and when you are not sure about the side effects of the particular drug. You are unnecessarily exposing such patients to the new the unknown effects of a new drug. And not only that, it also adds to a greater economical and ethical burden. So is sample size calculation required only for prospective studies? No. Sample size calculation is required not only for prospective, it's also required for descriptive as well as retrospective studies. And the source of this one is many times we have to, at the number of data what you are supposed to collect, number of patients you are supposed to collect, you have to plan in advance by calculating the sample size. Once you have understood what the importance of sample size calculation, I'll just go through a quick calculation of sample size in view. In this, I'm trying to take an example of the lipid profile changes in pre-eclamptic women to normal pregnant women. We are trying to compare what is the changes that can occur in pre-eclamptic women compared to normal men. So this is an article which is a similar study was done earlier in 2011, where they tried to estimate the lipid profile in subjects with preeclampsia. So in that, in the results, they observed that the cholesterol in normal pregnant women was 232.9 plus or minus 2, whereas in pre-eclamptic women, it was 262.5 plus or minus 4.5 milligram per deciliter. We'll just keep that in mind. And I'll just go through the calculation of sample size. This is a software which is freely available for calculation of sample size, that is openepi.com. I'll be explaining about this in the coming slides. So I just click on the sample size, go on the mean difference. So I enter whatever value I got from there. Let us say, I hope I am my screen is visible to all of you.
Can you make it full screen?
Sir, I've made it full screen, sir. This is the maximum. I mean, okay. Yeah. Is it better, sir, now?
Yeah, it's okay. Okay.
Yeah. So I'm in. It's the first column is confidence interval 95%, power 80%, ratio of sample size between group 1 and group 2 1. So if you remember, one group had 242.5 plus or minus, let us say 2.5, whereas the other group had 265.4 plus or minus 4.5 as the values. So I just entered these two and I calculated the sample size, and the sample size obtained is 1 in each group. Now I just entered some values and I got to the sample size. Now you might be wondering, how did I enter all these data and how did I get to know what does this confidence interval mean? What does this power mean? What does this group 1 mean and standard deviation mean? Where did I get this group 2 mean and standard deviation? This is what is going to be discussed in the next few slides. Okay. Okay. So whenever we calculate a sample size, there are few requirements. We all know whenever we try to cook some dish or anything, generally what we do, first we take all the ingredients according to the requirements and you just place it in separate bowls, and this one segregate it so that it is easily available at your hands length. And second thing, you keep all the vessels, utensils, everything ready before you cook. And finally, you go through the recipe once if you are not familiar with before you start the actual procedure. Likewise, in calculation of a sample size, we require certain things to be kept ready before we calculate sample size. Number one is the hypothesis. We should always form a hypothesis, or we should always come with a hypothesis before estimating the sample size, because it's very important. You should know, like, if you know hypothesis, then only it's easy for you to assume the values or make certain assumptions with regards to the values that are to be entered into the software. Number two is decide the primary outcome. As Dr. Rakesh sir discussed in the previous literature, in his previous talk, he was talking about one outcome measures. The outcome measures can be very varying. Like it can be anything, whatever you might try to measure anything from in a particular study, but you should choose one of them to be as a primary outcome measure. And once you decide one of them to be a primary outcome measure, describe them or quantify them in the terms of mean, proportion, and percentages as required. And third thing is you make certain assumptions. Now, what are the assumptions what you are supposed to make? One is regarding the errors. One is alpha error, beta error, in which includes power and class intervals, because they are confidence intervals. They are nothing but the contemporaries of alpha and beta errors. And next is effect size and variance. Now, what are these things? Let us come with the first point, that is hypothesis. So before that, there is something called study design, what you should understand when you are calculating sample size. Some of the softwares do require ask about the study design, because there are, as we all know, there are two types of study designs. It might be parallel study where we have two different groups. For example, group A and group B, both of them are receiving the intervention simultaneously through the trial during the period of trial. Whereas in crossover study, the same patient will have group A medication or type medication A during the first 6 weeks or something, or then switch over to medication B in the next 6 to 12 weeks. So this kind of study is known as crossover study. So you should define what kind of study you are doing, either parallel study or crossover study, because the sample size varies depending upon the type of study. And number two is hypothesis. What is hypothesis? Hypothesis is nothing but an educated guess. It's an educated guess about something in the world around you, and it should be testable either by experiment or observation. You can't just make an hypothesis. It should have a scientific background, and it should be testable, and either by experiment or by observation. And not only that, it should also contain both dependent and independent variable. For example, if you take something relating to medication, a new medicine, you might think it might work or it might not work. So if it works, then it is considered as alternate hypothesis. If you feel that it doesn't work, then it is considered as null hypothesis. Likewise, a new way of teaching you think might be better than the old way. So when you discuss about hypothesis, then there are two types of hypothesis. One is null hypothesis and the alternative hypothesis. Null hypothesis is an assumption where you think that there is no difference between the control and the study group in a RCT. If you want to quote an example, let us say you are giving a standard drug. Let us say you are trying to compare two different drugs. Let us say you are comparing morphine with buprenorphine with respect to the duration of analgesia in the post-operative period in patients undergoing abdominal hysterectomy, total abdominal hysterectomy. So what is the drug? One is morphine and buprenorphine. If your assumption is null hypothesis based on your scientific knowledge and literature, you mean to say that if the duration of analgesia with morphine, which is a standard drug, is, let us say, 6 hours, by adding buprenorphine, your assumption is that buprenorphine will also produce a duration of analgesia of 6 hours. This is null hypothesis. The second type of hypothesis or assumption what you can do is alternate hypothesis. Alternate hypothesis assumes that there is a difference among the two groups, and there is some association between the predictor and the outcome. For example, if you consider the same example, we assume that morphine produces a duration of analgesia of 6 hours, whereas buprenorphine may produce analgesia which may be more or which may be less than 6 hours, but not equal to 6 hours. That is what is alternative hypothesis. I hope that will make the point simpler. Once you decide about the hypothesis, next you aim for only one primary outcome measure. Just to cite an example, let us think that we are doing a study on post-operative analgesia where the outcome measure may be duration of analgesia or 24-hour analgesic requirement. You can choose any one of them. It's not necessary that it should always be duration of analgesia. It should always be 24-hour analgesic requirement only. You can also describe about the quality of analgesia with respect to the change in VAS scores. Like, you can select anything, but you have to decide that it is the primary outcome measure, so that you can measure you can calculate the sample size based on those primary outcome measures. If you take one more example, let us say if you are trying to study the effect of a drug on ICU outcome. Let us say you are trying to study the effect of coconut oil in patients taking aluminum phosphide poisoning. So what can be the outcome measure? Outcome measure can be duration of ICU stay, or if they go into respiratory failure, the duration of mechanical ventilation, or even mortality. The percentage of patients, the percentage of patients dying after receiving coconut oil, and compared to those who are dying without receiving coconut oil. So likewise, you decide upon one primary outcome. And once you decide the primary outcome, you quantify them in terms of mean and proportions, depending upon the type of variable. So suppose if you are using a quantitative variable as a primary outcome, let us say duration of analgesia. Duration of analgesia is always expressed as a quantitative variable because it is numerical variable. See, for example, it is always measured in terms of like hours and minutes. So they are all basically measurable variable, and hence they are known as quantitative variables. So you describe them or quantify them in terms of mean or median, like that. Whereas if you are using something like comparing the incidence or proportion of a disease, for example, let us say you are trying to measure the incidence of PONV reduction in the post-operative period between two drugs, for example, granisetron versus onisetron. You try to quantify them in terms of frequencies and percentages. This is mainly useful for nominal characters or ordinal variables. Okay. So I will just skip the group exercise. To study the effect of diabetes mellitus on neonatal outcome, the primary outcome measure can be blood sugar levels at birth, insulin levels at birth, and birth weight, Apgar score, ABG1. You can choose any of them as one of the primary outcome measures upon which the sample size can be calculated. Likewise, comparison of carbetocin. Carbetocin is a newer oxytocin derivative which is introduced in the market. So if you want to compare the effect of carbetocin and oxytocin for uterine contraction during cesarean sections, what can be the primary outcome measures? It might be intraoperative blood loss after delivery, or it can be, you can measure the quality of uterine contraction as assessed by the obstetrician, or the incidence of hypotension. Because you have given spinal anesthesia, you want to know which drug causes more hypotension when given as uterine uterotonic. So this is about the primary outcome measure and quantification of them as one of the quantification. Next important assumption what we are going to do is effect size. Effect size is nothing but the minimum difference what you are trying to detect between the two groups. Okay, so it is the minimum difference what you are trying to detect between the two groups. Now, how do you get this pilot size, effect size? Effect size is basically, most of the time you can go through some of the previous studies and articles, and let us see, you can observe what is the difference between the two groups and see if you can take up the same difference itself for calculation of sample size in your study. Or if it's not available, you should go, you can try and do a pilot study and obtain the values from there and try to use that as a use that for calculating the effect size. Or you can use the expert advice like guides and HODs or some senior persons who are already experienced in that particular field, and they can be helpful in giving you a minimum effect size which can be detected between the two groups, or by using your clinical judgment. So let us say, if I put it in an example, again, if we consider analgesic efficacy as one of the outcome parameters in a study. So if you want to study, if you want to detect, there should be a minimum difference of some minutes between the two groups to say that drug A is better than drug B. So for an example, we can keep a minimum difference of 30 minutes between the two groups with respect to duration of analgesia. So let us say if you, if I quote the previous example of morphine and buprenorphine itself. So in the previous study, it was observed that morphine would provide an analgesia of 300 plus or minus 30 minutes. So you assume that buprenorphine would produce an additional 30 minutes to make it clinically effective. So only if it produces another 30 minutes extra when compared to morphine, only then you can say that it's clinically better or clinically more effective than morphine, or else it's not better. So that is the minimum, that is the effect size what we were discussing. So that is the effect size, what the difference what you are anticipating to occur between the two groups. And next, another important assumption what we are thinking about is the variance. Variance is nothing but the degree of deviation that is you expected to observe. For example, this is mainly applicable to the mean values. Let us say if you are trying, like going back to the same example, like the analgesic duration with respect to morphine and buprenorphine. All this time we were discussing about the mean duration, the difference between the mean duration, that is 300 plus 300 and 330. But we also know that when we take the value of individual patients, let us say we assume we involve around 10 patients in the trial run or in the pilot study, and we observe like for example, one patient had 290, one patient had 340, one patient had 380 minutes of duration of analgesia. Likewise, 10 patients had different values. So what you mean to understand is not all patients will have a single value. So you are trying to find out a single or a value which is sort of near to all their values, and that value is the mean value, and that mean value is what we are using as one of the parameters to be entered in sample size. The other thing what you have to understand is the measures of dispersion, or the degree of each value that can move away from this central value. That is, if you consider the 300 minutes as the mean duration, so some patients can have plus 10, plus 20, some patients have minus 10, minus 20. So what is that average variance that can occur around these values is nothing but the standard, is nothing but the variance. And this variance is usually expressed in the form of standard error and standard deviation. But for all practical purposes or calculation purposes, we generally assume the standard deviation as one of the parameters of variance. So this is again obtained from your pilot study, or it can be obtained from previous studies also. And it is usually applicable, as I mentioned earlier, for continuous variables only, whereas for proportions, this kind of variance is not required. So just to throw an example in this direction, so let us say the duration of analgesia with drug A in 2 studies was 235 plus or minus 30 minutes and 365 plus or minus 60 minutes, because there are 2 different populations in which the drug A has been studied. So what will be the variance? Variance is nothing but 30, you see the standard deviation of 30 in one group, one study, and 60 minutes in the other group. So if you want to assume a variance for your study, what you can do is you can take the average of these two. So that is nothing but 30 plus 60 divided by 2. And so the assumed variance is around 45 minutes in your study. So this 45 minutes is the standard deviation what you are going to enter in group 2. So this one further, when I calculate in the when I show online calculation of sample size in the subsequent slides, you will be able to understand it better. So these are some of the examples. So anyway, I'll move on to the next prerequisite or requirement. Here I would like to spend a little time, because alpha and beta errors are some important to understand. It's not only from the point of calculation of sample size, it's also from the point of view of your examination. So type 1 error or alpha error is the error. See, for that, before going to the errors, what we need to understand is, whenever we do a study, we actually assume an outcome to be observed when you do a study. For example, let us say when you do a study, let us say when you add intrathecal morphine to bupivacaine for post-operative analgesia, you assume or you expect that post-operative analgesia is prolonged by addition of morphine. It's not always necessary that it should prolong analgesia. It might not also, not on all patients, because every patient is different, and there is always an individual variation in each patient, and you might not get the same expected result in all the patients. Maybe in out of 100 patients, if you give around 5 or 6 patients may not get the prolonged analgesia. So this can happen because of various patient factors, various bias factors. So many things can interfere with the this kind of negative outcome. So your idea is to, as long as possible, try to keep this kind of spurious negative outcomes and spurious positive outcomes to as minimum as possible. So one attempt among them is to mention the types of errors. Among them, the first, or the type 1 error, is also known as alpha error. Now, what is alpha error? Alpha error is a type of error which actually detects the difference between the two groups when actually there's difference doesn't exist. For example, let us say you are adding two different groups of drugs. For example, you are adding dexmedetomidine 3 micrograms and 5 micrograms to the intrathecal bupivacaine for some spinal anesthesia. Ideally, when you add these two drugs, in actual sense, 5 micrograms and 5 micrograms doesn't produce any significant, it may not produce any significant difference in the duration of analgesia. That means the duration of analgesia produced by 3 micrograms is same as duration of analgesia produced by 5 micrograms. Okay, so that is what. So this is null hypothesis. But by chance, because of some bias creeping into the study, because of a patient or because of some other reason, patient might express a difference between the two groups, like difference in analysis between the two groups, and you end up finding a positive result when actually there is no positive result. So this kind of an error is known as alpha error. This represents the chance of a researcher detecting a difference between the two groups when in reality no difference exists. In other terms, it's also known as false positive. So type 1 error is nothing but false positive. Next is type 2 error or beta error. This is one where this is a type of error which can creep up when null hypothesis is where it accepts null hypothesis when actually it doesn't exist. For example, in other words, if I have to simplify it, as I discussed earlier, let us say morphine and fentanyl. We all know that the duration of analgesia is definitely longer with morphine when compared to fentanyl. So there is an alternate hypothesis, that is fentanyl is shorter acting than morphine. But in certain patients, the result might not be the same due to some erroneous or intrinsic factors. And this detection of this false negative is known as the beta error. So this does not that is, this type 2 beta error represents the type of the percentage of patients in whom the difference between the two groups is not detected when in reality the difference exists. In other words, it is the false negatives. So power of study is nothing but the complement of beta error. So if you want to put it in a very simplified way, see, for example, it's like alpha 1 error or alpha error or type 1 error is nothing but it is like saying a male that you are pregnant. We all know that male will never become pregnant, but still we say that male is a pregnant. So that is false positive. Likewise, when you examine a female patient who is pregnant and say you are not pregnant, so this is type 2 error. That is, there are less chances of this one. Already she is pregnant, that the difference is there, but you are not able to see the difference and you say that it is not existing. So this is known as false negative, type 2 error. So next is the power of study. So power of study is nothing but it's a complement of beta error. It's the ability of the study to detect the actual difference that exists between the two groups. So it's the ability of the study. So suppose if you do a particular study 100 times, the power, if let us say if the power of study is 80%, that means 80 times out of 100 times the study, if you do the study repeatedly with the same methodology, 80% of the times it is able to detect the difference between the two groups. Only in 20% of the times it's not able to detect. So in other words, in 20% is the beta error. So the complement of it, or 80%, is the power of study. So mainly the power of study is it represents the strength of the study. So greater is the power, higher is the strength of study. Greater is its repeatability. Greater is its validity of the observation. So that is why we always try to keep a power at least at 80%. A power of less than 80% says that the repeatability of the study is not that much as you think. So suppose if you detect a difference between the two groups in the present study, when you repeat the study multiple times, there is a tendency that you may not pick up the same difference between the two groups, or you might not pick up a difference between the two groups in subsequent studies. In other words, the chances of accepting alternative hypothesis or alternate hypothesis comes down with the lower power of study. So that is the meaning of power of study. So even when you calculate a sample size, now what is the importance of this power of study with respect to sample size? I'll show in the subsequent calculation when we try to calculate the power of study. When you try to calculate the sample size with respect to power, the power of study usually increases with the increase in the sample size, whereas it decreases with the decrease in sample size. Likewise, if you keep the difference between the two groups to as minimum as possible, it will increase the power of study. If you keep the difference greater, the difference lesser will be the power of study. So as a customary or as a corollary, we always keep the alpha error lower than beta error. That is because many times you don't want to unnecessarily falsely approve a drug by a trial and allow it to circulate in the population and expose a greater population to a unknown side effects of that particular new drug. So that's why it is more detrimental. You are causing more harm to the general population by keeping the alpha error at a higher side. So that's why generally we keep alpha error at 0.05 and the beta error at 0.2. So at this point of time, this is one question which is raised quite often in my lectures. One is they ask whether alpha error and p-value are they the same, because many times we say p-value less than 0.05 is significant, alpha error we keep less than 0.05 to calculate the sample size. Are they the same? Because for the simple reason that you are using the same number. No, they are not same. They are actually different. Now so what is the actual difference between them? The alpha or the significance level is the probability that you will make the mistake of rejecting a null hypothesis when in fact it is true. For example, as we discussed in the earlier slides, alpha is nothing but the ability to pick up the difference between the two groups when actually it doesn't exist. It doesn't exist, but you're still trying to you're still picking up the difference. So that is alpha error. Whereas p-value measures the probability of getting a more extreme value than one you got from the study adjustment. So this sentence, if you don't understand, I'll just put across a example. This is an example. See, let us say you are doing a study on with respect to placement of intrathecal, let us say clonidine, for post-operative analysis in patients undergoing lower limb surgeries. Okay, so in group A, that is plain bupivacaine group, the duration of analysis is 255 minutes. Whereas in group B, where they received a intrathecal clonidine plus bupivacaine, the mean duration of analysis is 365 minutes, and the p-value is 0.002. So what does this p-value say? It simply says that if you notice, the difference between group A and group B is only 110 minutes, isn't it? So this p-value simply states that if you keep on doing this study multiple times, let us say you are doing the same study with the same methodology multiple times, the probability of the difference between the two groups coming to less than 150 minutes or more than 250 minutes, that is the two extremes of this particular value, that is 110 minutes, is 2 in 1000 times. So if you do the study 1000 times with the same methodology and same drug and same technique, the probability of detecting the decrease in the difference being either 50, less than 50 or more than 250 is only 2 times out of 1000 times. And hence, if the p-value is lesser than your alpha error, set alpha error, then your null hypothesis is rejected. And hence null hypothesis is rejected. So whenever p-value is greater than alpha error, let us say when you're calculating a sample size, you assume an alpha error of 0.05, and when you calculate the results and finally you notice a p-value of 0, let us say 0.58, that means you accept null hypothesis. That means there is no difference between the two groups. At the same time, if the p-value is less than alpha error, let us say if the alpha error you assumed while calculating sample size is 0.05 and the p-value is 0.002, that means at that point you can safely reject the null hypothesis and you can support the alternate hypothesis. So that is what is meant by that's what is the relation between alpha error and p-value. Okay. So now coming to the final part of the sample size estimation, that is, how do you calculate? You can either calculate based on formula or based on software. So formula based, if you go to the statistician, they will give the formula, they will calculate based on the sample. Now, before going to the sample, the entire the crux of this entire lecture was to make you understand what you need to take to the statistician to calculate the sample size. So he will have the formula, but you should take certain ingredients for him to feed into the formula. So what all to be fed is what we discussed in the last 15 minutes or so. So these are the various formulae which can be used for. So for further details regarding this formula and other things, you can always go back to our IJA edition of PG edition of 2016, where the entire PG edition is dedicated for research methodology. So in that, a separate article is there for sample size estimation, which is beautifully written by one of our authors, Dr. Sabyasachi Das, and that will give you more insights regarding the formula and other things. If you come back to with respect to the sample size, there are so many various parameters that can be used for sample size estimation, various softwares used for sample size estimation. So with this, I would just calculate one or two, maybe I can just show one sample size estimation, this one now. So we'll just go through one just for an example. Now that you have understood, we are trying to study the effect of two different. Let us say say that we are trying to study the effect of intrathecal clonidine on post-operative analysis and with respect to post-operative analysis in patients undergoing lower limb surgery. So in this, what is this confidence interval mean? This confidence interval is nothing but the reciprocal of the alpha error, or if alpha error is 0.05, you keep the confidence interval at 95. That means 95% of the times it is able to detect this much amount of difference. Okay, so that is 95. And next power, already I told, when you consider beta error at 0.2 or 20%, power will be automatically at 80%. So, and then the mean values you need to enter. So let us say now, as I discussed earlier, since clonidine is a new drug, let us say clonidine is a new drug and there is no literature available with regards to the duration of analgesia by addition of clonidine. But from previous literature, we know that by giving intrathecal bupivacaine, let us say 2.5 ml, the duration of analgesia is 180 minutes plus or minus 15 minutes. Now, how do you get this 180 plus or minus 15 is from the previous literature. Okay. And next assumption what you are going to make is the effect size. As we discussed, to be clinically significant or clinically meaningful result, you say that clonidine should produce a prolongation of analgesia. That is your alternate hypothesis. You are assuming an alternate hypothesis saying that clonidine is going to prolong the duration of analgesia when compared to plain bupivacaine. So that is what is your alternate hypothesis. Now this study is being done to prove or disprove this alternate hypothesis. That's what we are trying to do. So as per previous study, bupivacaine intrathecal will produce 180 plus or minus 15 minutes of duration of analgesia. So to make it clinically meaningful, that at least it should produce another 30 minutes of prolongation to say that it is clinically or statistically significant. So you add 30 minutes to 180 minutes. So eventually your proposed or your assumed duration of analgesia with intrathecal clonidine would be 210 minutes, and then the standard deviation again you assume it somewhere around 20 minutes. Now you might ask, sir, how did you get 20 minutes? This is just an assumption. Generally we assume a greater standard deviation when compared to the control group. When compared to control group, it's always better to take a higher standard deviation. That means you assume that the degree of dispersion of values in the study group will be much wider. So if you assume this one, you will be more safer when you calculate the sample size. So if I give calculate, automatically you got the value 6 in each, so total of 12. So this is about calculation of now. So let us see now what are the effects of changing the power and confidence interval with regards to sample size. I am not changing the effect size or standard deviation. I'm just changing the power of study to 90%. By making the power of study to 90%, what I'm trying to do is I'm trying to improve the preciseness of the study, or I'm trying to make the study more precise. So by increasing the power to 90%. So by keeping rest of them the same, I'm just increasing the power to 90%. So automatically you saw the sample size, which was 6 in each group, went up to 8 in each group. So that means by increase, whenever you want a study with a higher power, your samples will also increase. At the same time, let us say now the same thing happens when you try to increase the confidence interval. Now the confidence interval is 95. I increase it to 99. You see the sample size further increase to 11. Okay. So any increase in these two parameters will actually increase the sample size. Likewise, the effect size also got a influence on sample size. Greater is the effect size, smaller is the sample size. Smaller is the effect size, greater is the sample size. Now we have entered 210. Let us make it 190. And this one at 95 confidence interval and power at 80%. If you calculate sample size, see automatically it jumped from 80 to 6 in each group to 50 in each group. So the narrower is the effect size, greater will be the sample size. So this is the influence of each parameters on your sample size. So now once that is done, so this is with respect to the calculation of sample size. Now once you have calculated the sample size, how to put it best in the literature? That is the next question. Before going to that, one more interesting aspect of sample size. One is dropouts. Now, what do you mean by dropouts? Dropouts are nothing but whenever you recruit a number of patients in the study, it's not necessary that all the patients will end up completing the study. Many times the patient might be removed from the studies because of various reasons. So you have to compensate them for in the initial stage itself by adding an extra cushion to the calculated sample size. So dropouts may be due to the patient refusal. They might refuse to undergo the study, or sometimes they might not be receiving the allocated treatment due to various reasons. For example, let us say you are doing a study on laparoscopic cholecystectomy, intraperitoneal installation of local anesthetic for post-operative analgesia in laparoscopic surgery. So eventually what happened during the course of the surgery, they noticed that the surgeon has noticed that a lot of adhesions are there, and you convert it from lap to open. So what happens? You will not pursue that study further, and you will not give intraperitoneal placement of local anesthetic. So therefore, he will not receive the allocated treatment. So this patient will be considered as a dropout. Likewise, patients, when you follow up the study, for example, you are monitoring the duration of analgesia. So many times you would have given the ward nurses to give analgesia only at VAS score 3. They would wait till VAS score 10 and give analgesia. So invariably, the treatment is not denied. It's denied due to problem with the improper communication. Again, these patients, there is a violation of protocol. So again, all these parameters will result in certain dropouts. So you have to cushion for this in the beginning itself by adding 10 to 15% of the calculated sample size to get the final sample. For example, let us say if your calculated sample size is 24 in each group, so total patients is 48. You add another 48. So 10% of 48 is 4.8. You go to the next integer, that is 5. So you add 48 plus 5, 53 patients to the total group. to compensate for this dropout. So that will be your actual sample size, final sample size will be 53 and not 48. Once that is done, now finally, how do you put it in the literature or in your paper? A sample of 24 patients in each group would be required to keeping a power at 80% and confidence intervals at 95%. We included 35 patients. Is it a good way of writing the sample size? Well, this is not, because it is not giving a complete information. In order to give it a complete information, it should be measured in a proper way. See, assuming a blood loss of 350 ml is what, so you are making an assumption of 350 ml and a standard deviation of 15 ml, keeping power at 80% and confidence interval at 95% or alpha error 0.05%. A sample of 20 patients would be required to detect a minimum of 20% difference in the amount of blood loss between the two groups. So you are trying to mention the effect size here. This effect size is this is the effect size, this is a beta error, I mean, or the power of study, or this is the alpha error, and you are also assuming what is the blood loss in the control group and as well as the standard deviation, what all you are assuming. So you are assuming the effect size. All these assumptions are being clearly mentioned here, and so sample size calculated is 24, but you finally include 27 patients in each group to compensate for possible drops out. So this is the complete, so when you read this, it gives a complete information of how do you calculate the sample size. So that's the end of my talk. I hope it has covered most aspects of sample size estimation as well as the errors and hypotheses, etc. Over to the organizers. Thank you, sir. Sorry if I have taken longer time.
No, Dr. Sudesh, time is not a problem. And do you want to answer the questions in the chat box, Dr. Sudesh?
Yeah, sir. However you say, we are ready for that. Myself and Dr. Rakesh is ready for that.
Yeah, we'll go, clear the statistics questions. Then we'll go to the next. Can you see the chat box?
Yes, we can see, sir. With somebody is asking for PPT, as Dr. Sudesh mentioned, we have a full issue of ISA 2016. So all those articles we can share with the organizers and they can send it to everybody. So that are very useful articles for the same. So Dr. Saleha wants to ask how accurate it will be if I take a sample size to be all the patients fulfilling inclusion criteria during the study period. So as we mentioned in the method section, the sample size a priori calculation is different from the inclusion criteria. So they should not be mixed with each other. Sample size has to be calculated. So it is based on your primary objective or whatever you have taken as a research question with primary outcome. So those will define for a sample size calculation. For this, either you need to have some preliminary data from a published literature, or as Dr. Sudesh has mentioned in his presentation also, based on some clinical value of some clinical difference with the new intervention. Based on those, you can try to take a sample size. Now, sample size, once you take a sample size, when you start recruiting, so once a patient is eligible for recruitment, then only you can do a further randomization. So there are two different aspects. So I think you should not be mixing them each other. So sample size, for example, say 100 patients, you find 100 eligible patients for you, and then you recruit them, and then you start randomization as per the random number allocation that you have done it. So that needs to be done. Sometimes when you are doing a pilot study, and then on those pilot studies, depending upon the type of study, if there is no preliminary data, a sample size of 30 to 40 may be appropriate for us as such for a pilot study where there is no data available and you want to calculate some basic idea of how to recruit a particular number of patients, then you can do a pilot study. And then you can say all patients who are coming to my operation theater for this duration, for 1 month, they will be recruited, or this number of patients will be recruited. So these are two different aspects that needs to be taken care. And I think Dr. Sudesh can answer this. How can we quantify alpha error to compare with p-value? So quantification of alpha error, I can further add to request Sudesh to clarify. that how
No,
can
sir, you
we
can add. Already it has been added.
how
Anyway,
can
there
you
is no alpha error is always considered is in assumption, as I discussed earlier. It is an assumption. It's always preferable to keep alpha error as low as possible, because you don't want unnecessary positives to be seen when there is no positive existing in actual sense. So, for example, let us say if there is no difference, you cannot detect a difference and suddenly show if you allow that drug to be marketed in the society, many a times it might result in more harm than benefit to the patient. So that's why it's always preferable to keep the alpha error as minimum as possible, depending upon your study. For example, if the study outcome is not very very severe, for example, if you're doing a study on duration of anesthesia, etc., you can keep the alpha error at 0.05. That is acceptable, because you don't want to have the side effects. You have to keep the side effects as minimum as possible. At the same time, you are trying to study the effect of a drug on mortality. Your alpha error should be as low as possible, because you cannot allow the patient to die for the sake of your study. So you have to keep the alpha error as minimum as possible, where if you're doing some study with respect to mortality. So it depends upon the type of study what you're doing, and it also depends upon the what parameter or what outcome measure you are using as one of the assessment tool for your study. And second thing, as I told earlier, the p-value is a value which is obtained after your observation, whereas alpha error is a assumption what you're making. Okay, so you already assumed an alpha error, and if your p-value whatever is obtained after the study is done and after the results are tabulated, and if the p-value is greater than alpha error, that means you accept null hypothesis. If the p-value is lesser than the alpha error, then you accept alternate hypothesis. That's what I hope the question is answered.
just to add on, in case if you come down with your alpha, the sample size is going to high, because you are accepting lesser error. So it becomes important to understand this fact also. So if you are taking alpha 0.05, 5% versus 1%, the 1% of alpha error will make sample size going up. So you should be, when we talk about the feasibility of a study, you should be able to get those number of patients in whatever duration you want. Now, there are two questions which are related to pilot study. One is by Dr. Swati. She wants to ask, is pilot study same as interim analysis? No, they are two different things. Now, I think I should take a liberty to explore the interim analysis also. Interim analysis is not a routine. It has to be a priori defined in your protocol if you are looking for interim analysis, because if you do an interim analysis, you are defining the randomization process, because the randomized process is already going on because you do not know. So you open up. So when we say randomization and blinding, so blinding is off if you do an interim analysis. So interim analysis is usually not done, but in certain studies where the adverse reactions are coming up, a separate committee which looks after the drug reactions, they can look after the drugs reaction, and they found a significant number of patients having significant adverse reactions. They can open up the blinding and look for that which group is better, to look for whether study should go on or further. So interim analysis is not the routine for any research, until unless for some specific reason, if we have decided a priori in your method, then only you should interim analysis. And how many subjects to include in pilot study to take it for a sample size calculation? If you are doing absolutely for a novel study, usually it has been seen that you may have experience from your center doing the similar number of cases, so you can collect all those data. But on an average, we say that 30 to 50 patients in each group is usually acceptable as a pilot study for defining a sample size. But remember, if you find some difference in the parameters for sample size calculation in a pilot study, if it does not match the actual study, then you should mention it as limitation. So we need to understand. For example, if a pilot study says that drug A and drug B leads to reduction of the morphine consumption in post-operative period by 10%, and if your actual study says only 5% or 20%, then this means your sample size calculation based on the previous study is not appropriate. So if it is going up and down, you should mention it as a limitation in your actual study. And that are the nitty-gritties of mentioning the limitation section of your discussion section, where you explore that you assume that this would be reduction in the requirement of opiates, but actually do not find it. So your sample may be underestimate or overestimate, and accordingly you should mention in the limitation of your study. Can you elaborate on confidence interval? Yes, Dr. Shudesh has already decided it will be a statistics part 2 next time, and we'll be exploring more upon the confidence interval, standard deviation, p-values, which we have discussed, and how to clinically interpret these values from clinical sense. So in next session, which is being done by ISA Kerala PG update, we'll be coming up with these values also, with these concepts also.
Thank you, Dr. Rakesh and Dr. Sudesh. I think that with that we have covered the chat box questions also.
Yes, sir.
Can we go? Yeah. Can we go to the next session?
Thank you very much, sir. Thank you very much for the opportunity.
Thank you, sir.
Thank you. So the next session is a case presentation by will be chaired by Dr. Sunil Nair and Dr. Sunil Rajan and Professor Gedo. Over to Dr. Sunil and Dr. Gedo.
In between, Dr. Rajesh, you can announce our next program, which will be held on next Saturday.
Yeah, next Saturday we have a neural protection in spinal and intracranial surgeries by Dr. Sulfikar. He's an additional professor from SKIMS Srinagar, and there will be a case presentation by scoliosis correction.
I'll share the screen and it will be visible for a second. I'll ask Anu to wait for a second. I hope it's visible now.
Yeah. This is truncal blocks.
Yeah.
That is by presentation by Dr. Nazar on 28th January.
28th January, Thursday.
But our PG update is on Saturday, next Saturday. That is Dr. Sulfikar Ali and case discussion on scoliosis correction by Dr. Examiners are Dr. Rakhavendra Pai and Dr. Baburaj. So over to today's case presentation. Dr. Sunil.
Today's case is oral malignancy with defect airway, and Dr. Anu, who is our third year PG student, should be presenting the case. Over to Anu.
Yes, sir. Good evening, sir. Good evening, everybody. Shall I start presenting, sir?
Yeah.
Yes, Anu, you can present.
Yes, sir. My patient, Mr. Rajendra Pillai, is a 63-year-old male patient who is a farmer by occupation, hailing from Changnasheri. He presented with a complaint of ulcer in the tongue with associated pain since the last 3 months. History of presenting complaint: patient noticed a small lesion on the left side of the tongue 3 months back, which progressively grew in size to the current status. It started off as a painless ulcer, but since the last 2 weeks, he has associated pain and difficulty in moving his tongue. He consulted a dentist who pointed that he had multiple caries and a sharp tooth near the lesion, which was scaled off, and he was referred to our hospital. At our hospital, a biopsy was done from the lesion on OP basis. He gives history of occasional bleeding from the lesion, especially on brushing his teeth. There is no history of difficulty in swallowing, ear pain, or neck swellings. No history of recurrent ulcers, oral ulcers, white patches. No history of recent loss of weight or appetite. History of past illness: he's a diabetic since 7 years on oral medication. He's a hypertensive since 5 years on tablet Silacar 10 mg twice daily. No history of ischemic heart disease, cerebrovascular accidents, thyroid disorder, asthma, or seizures. No history of any surgeries in the past. Personal history: he consumes a mixed diet. Sleep and appetite is normal. Bowel and bladder habits are normal. He's a known smoker since the last 30 years. He used to smoke about 10 to 15 cigarettes per day. Last cigarette smoking 2 days back. There is history of occasional alcohol consumption. No history of tobacco chewing. He has good effort tolerance. Family history, he has 2 siblings, both are healthy. Parents died of old age related illness. No history of similar illness in the family. Treatment history, he's on tab clinidipine 10 mg BD and tab metformin 500 mg BD. Going to general examination, he's afebrile, he's moderately built and nourished, he's oriented to time, place, and person, a height of 168 centimeters, weight of 68 kg, BMI of 24. No pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy, pedal edema. I was able to palpate hard, mobile, multiple lymph nodes on the left side of the neck. Vitals, pulse 89 per minute, regular in rhythm, volume, character, no vessel wall thickening. All peripheral pulses are palpable. Allen's test is normal. A BP of 130 upon 80 millimeters of mercury in right upper limb in sitting position. Respiratory rate of 18 per minute. Airway examination. One finger can be insinuated in front of the tragus on opening mouth. Mouth opening of 3 finger breadth. Jaw protrusion is normal. Upper lip bite test is normal. He is able to bite above his vermilion line. Tongue protrusion and side-to-side movements are restricted. A hyomental distance of 3 finger breadth, which measure to 5 centimeters. A thyromental distance of 4 finger breadth, which measure to around 6 centimeters. A Mullumbity score of 2. Next, soft tissue is normal in consistency. There is no evidence of fibrosis or contracture. No obvious swelling on inspection. Neck flexion is normal and neck extension is normal. Going on to systemic examination. All the systems are grossly within normal limit. Expiratory system, examination of the upper respiratory tract. Nose, no septal deviation, nasal obstruction or discharge, no nasal polyp, no flaring of ala nasi. Sinus points, no erythema or swelling over the sinuses, no frontal, maxillary or ethmoid sinus tenderness. Oral cavity, he has good oral hygiene, but he has got caried teeth as well. Tonsils are normal, no posterior pharyngeal wall congestion or postnasal dripping. Examination of chest, inspection, no apparent deviation of the trachea. Apex beat is not visible. Respiratory movements bilaterally equal. Rate of 18 per minute. Regular rhythm, thoraco-abdominal. No intercostal retraction. No dilated veins, visible pulsations, scars, sinuses, or edema over the chest wall. Palpation, trachea is central. Apex beat is palpated in the 5th intercostal space, 1 centimeter medial to the mid-clavicular line. Respiratory movements are bilaterally normal, and the chest wall measurements are also within normal limit. Vocal fremitus is normal on both sides. Percussion, equal resonant notes percussed out both sides. Liver dullness and hepatic dullness percussed out. Auscultation, intensity of breath sounds are normal. Normal vesicular breath sounds heard bilaterally. Cardiovascular system, pulse 89 per minute, regular, normal volume, character, no vessel wall thickening or radiofemoral delay. All peripheral pulses are palpable. 130 upon 80 millimeters of mercury arterial BP, and JBP was also not elevated. Inspection, precordium is normal, no visible bulges or retractions. Apical impulse was not visible. Palpation, apical impulse palpated at left 5th intercostal space, 1 centimeter medial to the mid-clavicular line. Auscultation, heart rate of 89 per minute, no pulse deficit, S1, S2 heard normally, no added sounds. Gastrointestinal system, in the upper GIT, no abnormalities detected. Examination of the abdomen. Inspection, abdomen scaphoid, umbilicus inverted, all parts move normally with respiration. No visible peristalsis or pulsations. Palpation, liver palpated 1 centimeter below the right costal margin in the mid-clavicular line. Spleen not palpable, no other masses palpable. Percussion, liver dullness, 6th right intercostal space in the mid-clavicular line to right 8th intercostal space in the mid-axillary line. Liver span of 11 centimeter. Renal angle is resonant. Auscultation, bowel sounds heard, no bruit or venous hum. Examination of groin and examination of External genitalia grossly within normal limits. Nervous system, higher mental functions are normal. Examination of CNS, motor system, reflexes, sensory system are all within normal limits. No signs of meningeal irritation. Examination of peripheral nerves are within normal limits. And skull and spine also within normal limits. Shall I summarize, sir?
Yeah.
My
Yes.
patient is a 63-year-old male patient, known diabetic, hypertensive, and chronic smoker, who has presented with an ulcer on the left lateral border, anterior two-thirds of the tongue, since the last 3 months, with adequate mouth opening and neck movements, but with restricted tongue protrusion. Planned for wide local excision, neck dissection, plus or minus a radial forearm free flap.
In the history, you have given a lot of importance to a sharp tooth. In the history, when you are taking history, you have given a lot of importance to a sharp tooth. Why?
Sir, the risk factor, the known risk factors for oral malignancies, one of them include teeth abnormalities like a sharp tooth, which causes constant irritation on the mucosa or the tongue. The other risk factors are like alcohol, smoking, any viral infections like hepatitis, human papilloma virus, Epstein-Barr virus, HIV, herpes simplex have all been associated with a higher incidence of oral malignancies. So the risk factors, I would like to again note them out as smoking, alcohol, a tooth which causes constant irritation, virus, exposure to radiation, familial like Xeroderma pigmentosa, pre-malignant conditions like erythroplakia, leukoplakia, submucous fibrosis, etc.
You told about some ear pain also. What is the significance of that?
Yeah, this patient did not have ear pain, but ear pain, there's something called referred autalgia, which is basically pain in the ear, non-autogenic in origin. So because of the common nerve supply, especially the trigeminal nerve, any ulcer, a painful ulcer in the oral cavity can be referred to ear, and patient can have complaints of ear pain.
Your patient doesn't have.
Yes. Anu, can I ask you some
Yes, sir?
questions? Yeah, I
Yes,
just
sir.
want to know, since you asked about the past history and all,
Yes, sir.
and patient is a known diabetic,
Yes, sir.
I think it is also related to the difficult airway plus your CA tongue. So
Yes,
can you
sir.
tell me what are the things which you missed in your examination during your clinical examinations, considering the patient is a difficult airway and plus diabetic?
A diabetic. Okay, so diabetic patients, if it is a long-term diabetes or uncontrolled
I
diabetes,
think
they can have.
8 year is quite a long term.
Yes, sir. Yes, sir.
Yes.
So they can have diabetic arthropathy. So I could probably have asked for a palm print sign or a prayer sign, which is suggestive of if the patient, the prayer sign is, I ask the patient to approximate the palmar surface of both the hands and press against each
That's
other,
exactly
oppose
what
the
I'm telling
palmar
you.
surface.
That's what I'm saying,
Yes, sir.
that you have not mentioned these two signs at all.
Yes, sir.
Moreover,
Sorry.
in the history, of course, I know he must be a fresh patient. Do you
Yes,
think any relevance of any either chemotherapy or radiotherapy for this patient? Suppose after post-radiation or post-chemotherapy, he is posted for the surgery. Does it
Yes,
have
sir.
any relevance for our anesthesia?
Yes, sir. Exposure to radiation therapy, neoadjuvant radiation therapy definitely adds on to our difficult airway,
How
because radiation can cause radiation. Sir,
how a radiation can?
radiation can cause fibrosis. Radiation can cause fibrosis of the neck, which restricts the neck movement. It can cause edema of the upper airway.
I think it is not the fibrosis of the neck that is more important for me. Right now, I'm considering only about the airway. I'm
Okay, sir.
radiating his tongue also. I'm radiating his neck also. Will the radiation to the tongue also can cause something for me as far as
Edema,
airway is concerned?
edema, sir.
Radiation to the tongue. If he has been given a radiation RT to the tongue also, and neck. Will it cause some problem for us?
It will further restrict the mobility of the tongue.
One saying anyway, mobility is not there anyway.
Yes, sir.
See,
It
it can
adds
cause
on to the airway edema, sir.
no. It can cause three problems if you give radiation. This for your knowledge. One, post radiation, there is chance that patient will have loose tooth.
Okay, sir.
Secondly, mucositis, and last but not the least, it can worsen the trismus due to post radiation fibrosis of the oral mucosa and all those things also. Because the oral mucosa as well as the tongue and everything may get replaced by the fibrosis post radiotherapy burn. So these will worsen our radiation. Forget the neck as of now. Of course, I don't deny neck is also a problem, but radiation also can cause a worsen the things more. So
Yes,
that
sir.
should have been mentioned, or at least if it is not given, fair enough. But still, it should have been mentioned that patient has not received any radiation or chemotherapy in the past. Because this is important,
Yes.
relevant finding. And then you should also know what are the side effects of the radiation as far as our airway is concerned. Now I'll come back to the
Okay, sir.
chemotherapy. Can you tell me which chemotherapy are normally prescribed for the head neck cancer? Because you belong to Amrita Hospital.
Chemotherapeutic agents. I'm not sure, sir. Sorry.
See, there are two radio chemotherapy drugs which are most commonly used. One is an adriamycin and
Okay.
second is a cisplatin. These are the most commonly used. Now I
Okay, sir.
want you to know what is the side effect of adriamycin. Let me say this patient has received 4 or 5 cycles of adriamycin. So what is the cumulative dose that is permissible?
Adriamycin as a side effect can cause cardiac
First thing,
toxicity.
yeah, first thing, tell me what is the cumulative dose of adriamycin, which is supposed to be a safe dose.
I don't know, sir.
Oh, okay. Write down
Yes, sir.
450 to 550 milligram per square meter. This should be the cumulative dose. But of course, there are some patients in whom even a single dose can produce acute adriamycin cardiac toxicity, even
Yes.
a single dose. But
Yes.
normally, cumulatively, it produces if you exceed this dose. So what will be the side effect if I suppose I give you the toxic dose? What will be the side effect that can happen of the
Of
adrenaline?
cardiac toxicity that can cause cardiomyopathy.
Cardiomyopathy is a chronic disorder. I'm talking acute. There are two types of cardiac problems. One is acute cardiac problem and second is chronic cardiac problem. In chronic, you get chronic cardiomyopathy. In acute,
Myocarditis, sir.
that's again a chronic thing.
Okay.
Or a patient who is hypersensitive. But a normal patient can have what? He can develop ventricular tachycardia, supraventricular arrhythmias. He can develop VPCs. He may develop blocks, conduction blocks, or at the most, he may also develop STT changes. These are the
Okay,
acute
sir.
changes. While in chronic, you may get into cardiomyopathy, you may get into congestive cardiac failure, or God forbid, cardiac arrest. These are the possibilities that can happen even in the chronic
Yes, sir.
cardiomyopathy. What about the other drug? That is
Cisplatin.
cisplatin.
Bone marrow suppression.
Only bone marrow suppression. Are you Googling?
No, sir. I'm notes.
I thought suddenly you started Googling.
No,
Yes.
sir.
So tell me, cisplatin causes bone marrow depression, but more important for us as an anesthetist, tell me, which is more important for me? I'm not bothered about bone marrow depression. It causes a renal toxicity. So any patient who receives cisplatinum, you must emphasize on what is your what you call creatinine level. And if your creatinine level is more than normal, you can also ask for creatinine clearance test. Because if at all still you have to insist, you may have to reduce the doses of neuromuscular blocker drugs.
Yes, sir.
Because that is important for us. You have to reduce your neuromuscular blockers. This
Yes, sir.
also should be remembered. So this
Yes.
is how creatinine plays a lot of role. It can also cause nephrotic syndrome, nephritis, and all those things.
Yes.
I don't know. I think I had published one article in Indian Journal of Anesthesia about implication of anti-cancer drugs. Anyway, it doesn't matter. Now come back to the patient. You have gone through the patient, everything file is been done. What workup you will do for this patient? Suppose I am the surgeon and I want to post this patient tomorrow. Now you tell me what all things are your requirement before you really post the patient tomorrow. Surgeons are restless. I want to post it tomorrow. Now you tell me and you convince me how you want to do it.
Pre-op investigations.
Tell me.
A routine blood count, CBC, hemoglobin, total count, differential count, platelet. I would like to, he's a chronic diabetic, so I want to send the renal function test as well, serum creatinine, blood urea. Then PT-INR, a baseline ECG. He's a hypertensive, he's a smoker, he's a diabetic, all risk factors for cardiac conditions. So I would like to take an ECG to rule out any previous MI or conduction defects or any abnormality. I would like a baseline chest X-ray. He's a smoker, so I want to look at emphysematous changes. More importantly, I want to look at any secondary metastasis from the oral malignancy.
Normally it doesn't go there.
You like to
Normally
have
oral
a
malignancy doesn't go to the lungs.
okay.
Okay.
Yes.
Like to have a serum albumin levels.
Serum albumin level, sir, he has got an oral malignancy, so he can probably be undernourished. So the nutrition, if the nutritional status is poor, he can have hypoalbuminemia, which as an anesthetist has implication to us because highly protein bound drugs like the induction agent we give propofol, the free factor of the drug will increase if patient has hypoalbuminemia, in which case we have to titrate our doses. Also, hypoalbuminemia is
Can,
implicated in
wait a minute, Anu. Which dosage you will have to alter or change with your low albumin? Let me say patient has got a low albumin. How
Yes,
it is
sir.
important for we anesthetists? Tell me.
Albumin,
Which drugs are bound to albumin?
propofol, opioids,
Opioid is okay, not propofol.
um,
Thiopentone.
thiopentone, alter the drug
What about the
dose.
Okay.
does it affect the post-op outcome?
Post-op, the rate of flap failure, the rate of wound dehiscence, etc., is higher with patients with hypoalbuminemia.
Depending with the other investigations.
Sir?
Other investigations you'll ask for? Your
He's a
ECG, whatever.
diabetic, so I would like to ask for a random blood sugar and an HbA1c to see the sugar control over the last 3 months. Blood grouping and cross-matching.
Okay. Can you tell me one thing? Do you
Sir.
want to find out what is the extent of your tongue lesion?
Yes,
How
sir.
you're going to find out?
You from the surgical side, I'm sure I'm hoping there will be an MRI to see the extent of.
Something went wrong. I can't hear you. Sunil sir, we can't hear.
Hello, Anu?
Sir,
Something.
can you hear me?
Yeah, now I can hear you.
Okay.
Now we can hear you.
So,
Yes.
so sorry, sir. I lost power in between. So sorry.
Yeah,
Okay.
continue.
Yeah. So I would like to. I would like to ask for an MRI to see the extent of lesion.
See
See if it's going into the.
why I'm asking this question, because he is unable to protrude out the tongue. So there is a very
Yes, sir.
high possibility that it is extended behind also.
Yes, sir.
Because anterior 2/3 of the tongue, he can easily protrude out the tongue, unless he is radiated and all those things.
Yes, sir.
Okay. Yeah. Yeah. Now you're investigated, and I tell you one thing. Fine, your investigations are okay. Next. Only thing, your sugar is 160. Fine. Next.
Next, about the NPO guidelines the day before surgery. I would like to discuss with the surgeon what surgery they are planning to
I'm
perform.
telling you, I'm a surgeon. I'll tell you, I'm going to do his hemiglossectomy along with the neck dissection, and if possible, as you have said, we may go for a free flap. You only said that. You have written it. Am I free radial
Yes,
flap?
sir.
Yes.
Yes, sir.
Next.
Next, on the day prior to surgery, I would like to write down the NPO guidelines and psychologically as well as pharmacologically prepare the patient for the procedure the next day.
Wait a second, madam. This your patient is a chronic smoker. You only said that. So don't you think you should
Yes, sir.
optimize the respiratory system also a little if given a chance? What
Yes,
is the
sir.
relation of
Ideal to stop smoking.
what is the relation of smoking?
Ideal to
Tell me relation
smoking
of smoking.
as yes, sir. Smoking increases the carboxyhemoglobin levels in the blood, which in a non-smoker it is less than 2%, whereas in a smoker the carbon monoxide levels are more than carbon monoxide levels are increased, which binds with hemoglobin and forms carboxyhemoglobin because its affinity to oxygen is 200. As affinity to hemoglobin is 200 times
So,
more than oxygen.
so you should
So
also
because of
say
the
if
increased fight to
so you should also say if the surgeon permits, I don't mind, extend the surgery by 7 to 10 days so that the carboxyhemoglobin level will come down to near normal. It may not take normal. It will take a longer time, but at least it will
yes, sir.
improve. Okay? You can say
Yes,
that.
sir. Yes, sir.
But if
Ideal
I,
to
yes,
stop smoking for 4 to 8 weeks prior to an elective procedure.
that much surgeon cannot wait and even cancer cannot wait. Okay? So 7 to 10 days is also enough,
Sir.
at least to improvise your carboxyhemoglobin
Okay, sir.
level. Next. Now everything is settled. Now
Yes, sir.
tell me, we have waited for 8 days. Tomorrow I want to post the patient. Today at 9 p.m.
Yes,
I
sir.
told tomorrow I want to post the patient. Tell me. How you are going to go ahead?
We talked about investigations, the NPO guidelines.
It's all done.
Okay. I would like to do a detailed airway examination.
That you've done already. Nothing new.
Okay, sir. So NPO guidelines, NPO for 6 hours for solids, 2 hours for clear liquids.
That has no meaning. Nothing. Next.
There's a plan of
Pre-medication.
The adult patient, he can stay overnight fasting also. Don't go with
Okay,
the
sir.
guidelines.
Okay, sir.
Next.
So pre-medication on the night prior to surgery, our H2 receptor blocker, a prokinetic, an anxiolytic like an alprazolam. And on the morning of surgery, we can give another dose of Rantac and a prokinetic like Perino, metoclopramide.
I know 1 minute. Since there's a plan of a radio from free flap, would you
Sir.
like to do any other additional tests when you see the patient on day before surgery?
If they're planning to take a radial forearm flap, I would like to do an Allen's test on that side. Also, if you're putting an arterial line on the other limb, I would like to perform the Allen's test to see the
Hey, that's fine.
patency.
Okay.
Sir.
Are you missing something even in the pre-operative orders? Because you said alprazolam
Yes,
and Nick.
optimization of his own medications. He can continue his antihypertensive, which is a calcium channel blocker,
Yes.
on the day of surgery. Diabetic oral hypoglycemic agents, best to withhold metformin for 24 to 48 hours prior to surgery because it can
No,
cause lactic
no.
acidosis.
It's not withhold 24 hours to 48 hours. It can
On
be
the day of surgery.
one night prior also he can take. Nothing wrong.
Okay, sir. On the day of surgery.
Now on the day of surgery, you know it. That's fine. And get the morning sugar done. That also should be ordered
Yes.
before the patient is
Morning.
subjected. Okay.
Yes, sir.
Next. Okay, patient is taken. Now I'm your assistant. I have put your IV line. I have put the leads. Whatever you want to tell. Everything I have done. Next.
My plan of anesthesia would be general anesthesia with nasotracheal intubation with positive pressure ventilation.
Okay.
Since his
Can you
neck
elaborate
movements
on the
and
OT preparation? Can you elaborate on the OT preparation?
yes, sir. OT preparation, he is an anticipated difficult airway. So I want to keep all the gadgets for difficult airway ready, like a video laryngoscope since it's available at my institute, bougie, tubes of different size, LMAs of different size, and second generation LMAs. An external help for a senior consultant or a senior anesthesiologist available for help if I'm in need. Suction must be kept ready. A fiber optic should be available
He is
if
a patient
I'm.
of a CA tongue, unable to
Sir,
protrude the tongue, as you have said. Are you going to
sir.
use the LMAs here? By
It is
putting
an
your
anticipated
LMA,
difficult. It
agreed,
is
but
an
if you are going to put LMAs, don't you think you are going to cause the bleeding and it can aspirate because patient is under GA?
sir. It is
And
if
there
my
may be
plan.
possibility that mouth opening may be limited. Your LMA may not be
Sir,
able to go.
sir, as a plan B, as a difficult airway card preparation, I would like to keep it on. I'd like to keep it ready if I'm not able to do endotracheal intubation after 3 or 4 attempts.
Okay, next, go ahead.
After securing the IV line, after attaching all standard pre-induction monitors, I would like to give a small dose of benzodiazepine, midazolam 2 mg, an opioid. I'm Since video laryngoscope with a deep blade is available, my first option would be to do an IV induction and
So
intubate.
you're sure of intubation with a video laryngoscope or laryngoscope?
Mouth opening is adequate and only tongue and
But
neck movements are also adequate.
there is a fairly big growth, and as I said you, since he is unable to protrude the tongue, that means the growth possibly may be going to the base of the tongue as well, posterior one third also.
Okay,
So
so
are you going
then
to put your laryngoscope blade onto the lesion?
it's on the left side of the tongue. So I will try to not traumatize as much as possible. The other option available will be
Madam,
to give, sir.
your laryngoscope goes always on the left side of the tongue only.
Okay, sir.
You always has
So
to
I
look
would
at
like
it
to
on the
do a
right
check
side of the tongue.
scopy to see if epiglottis is visible.
And
After
for
the
that,
check scopy,
madam, for check scopy also you'll have to give GA or you will do it without anesthesia.
I will give IV agents until the patient, but I will make sure that the patient
Before
is in
induction,
spontaneous
can you
respiration.
do a check scopy?
If, an inhalational induction can be done, and once the patient is.
Can you topicalize the airway and do a check scopy? Is it possible at this stage?
That's exactly
Yes.
what I was asking her. She's not committing that.
You can topicalize the airway and do a check scopy as well, sir.
How do you topicalize and do a check scopy before induction?
For topicalization of the airway, you should know the nerve supply of the upper respiratory tract. So the nose and the anterior part, sir?
No, I'm not asking anything. Continue.
Yeah, how do you
Shall I speak
topicalize?
about the nerve supply
No, how
of
do you?
the? Okay, so
What
I can.
are the nerves? Okay, tell.
Nerve supply of the upper respiratory tract, the nose and the anterior part of the nasal cavity is supplied by the anterior ethmoidal branch of the ophthalmic division of the trigeminal nerve. The posterior part of the nasal cavity is supplied by the greater and the lesser palatine branches of the maxillary division of the trigeminal nerve. Coming to the oral cavity, the anterior 2/3 of the tongue is supplied by the lingual nerve, which is a branch of the mandibular division of the trigeminal nerve. And the posterior 1/3 of the tongue, the base of the tongue, the epiglottis, the aryepiglottic region, vallicula, etc., is supplied by the glossopharyngeal nerve. And the larynx above the level of the vocal cord is supplied by the superior laryngeal nerve, and below vocal cord and below the vocal cord is supplied by the recurrent laryngeal nerve. So knowing the nerve supply, we go on to topicalize the airway.
Yeah, how do you do it?
The options we have are application of local anesthetic as soaked cotton pellets in the nostrils. The other option is to use lignocaine spray, 10% or 15%
For a
lignocaine.
check laryngoscopy, do you need to anesthetize the nose?
No, you can. You need to only anesthetize the oral cavity for the check laryngoscopy.
Okay.
So you can spray 10% lignocaine in the oral cavity. You can perform nerve blocks, but for check laryngoscopy, maybe not.
Can you tell me how to do the nerve blocks? Where exactly,
Yes.
location, landmark?
Yes, sir. Yes, sir. Glossopharyngeal nerve, there are two approaches. One is the intraoral approach and the extraoral approach. The intraoral approach, if is possible only if there is adequate mouth opening, in which case we ask the patient to open the mouth. We medially displace the tongue, and the landmark is at the base of the posterior palatopharyngeal arch near the third molar.
If this is a cancer patient with a tumor in the mouth and possibly, so don't talk in cancer patient anything intraoral. Always
Okay,
talk
then
extraoral.
Okay, sir. So the extraoral approach is called the peristyloid approach. So with the head in extension, the midpoint of a line drawn from the angle of the mandible to the mastoid, that is usually the styloid. So you take a 25 gauge needle with 5 to 7 ml of 2% lignocaine. You try to hit the styloid process, then walk it off posteriorly. And after negative aspiration, you can give 5 to 7 ml of 2% lignocaine. That is glossopharyngeal nerve.
Have you given it by any chance?
No, sir. We at our institute, topicalization is done with a transtracheal block.
Wait a minute.
And
That's
also,
what I'm asking you, because you said to me glossopharyngeal. Can you tell me what are the complications of glossopharyngeal nerve block, which you said extra oral?
The internal carotid artery is in very close proximity to it. So accidental intravascular.
Internal carotid is a lesser problem, because anyway, before you inject, you aspirate. So you'll not get blood. Any other thing which is very important?
Failure of block.
No, dear. Remember, the nerves come three together. Three nerves come together.
Yes, sir.
Okay? Vagus, glossopharyngeal, and hypoglossal. So
Okay,
5 to 7 ml can get overspilled to your vagus and hypoglossal also.
Okay, sir.
So patient can have vagal block, which is at the just exit point, and that can lead to any time any aspirations. So it is not a risky, and it is not indicated at all. Glossopharyngeal is not indicated. Instead, you should talk about superior laryngeal, transtracheal, and all.
Yes, sir.
Tell me how you do superior laryngeal block.
The superior laryngeal nerve, it winds inferiorly to the greater cornu of the hyoid bone and pierces the thyroid membrane to enter the larynx.
How you do it? Tell practical thing how you do it.
Okay. The patient with a neck extension, the hyoid bone is palpated, the greater cornu is palpated. With a 25 gauge needle, we try to hit the greater cornu and walk it off inferiorly. And then you aspirate. After confirming negative aspiration, you give 2 to 4 ml of 2% lignocaine.
Are you going to do it bilateral, unilateral?
Bilateral, sir.
That you are not committed. And second thing, it is to be given, you touch the greater cornu, feel the greater cornu, go half a centimeter lateral and half a centimeter above. And that's the point of entry. And then we have to fan out from the hyoid to the greater cornu, like that you have to fan out your spread of the drugs, that is 2 to 3 ml on either side. Then only it will block that thing.
Yes, sir.
Have you noticed that? I'm not sure whether I can, I don't know whether I can really show you. I don't know. Can you focus this, please? I don't know. Can you bring me on
I
the
cannot
screen?
see.
I had to come on the screen. This is the
I
diagram.
cannot
I
see,
don't
sir.
know. I can't say. I'm not sorry. I'm sorry. I think I should come in the main screen. Then only you'll be able to see. Doesn't matter. I'll send you.
Okay, sir.
So that is important. One thing. What about transtracheal? Where you'll give?
Transtracheal, patient supine position, neck extended, fix the trachea, try to palpate for the, you fix the trachea and 4 ml of 4% lignocaine. After confirming intratracheal positioning by
No, you are not told me the site.
bubbling of
You are not told me the site of puncture.
site of puncture
Puncture.
at the
You are
tracheal
not told me the
prominence.
site of
The,
tracheal,
the
tracheal prominence.
thyroid.
You can't go in thyroid. You are going transtracheal. How you can do thyroid? Thyroid is a cartilage, which is miles above the trachea.
In between this second and third tracheal ring or the first and second?
That's the place, my dear, for your isthmus of the thyroid.
Between second and
So
third tracheal
ideally,
ring.
you can say that you can give in the cricothyroid membrane. That is also enough.
Okay, sir.
Okay.
Yes, sir.
Next. Let me say, I'll now twist the question. This patient has got only 1 centimeter mouth opening.
Yes, sir.
And unfortunately, Amrita Institute doesn't have fiber optic. Next.
Yes, sir.
Next.
My options would be in the absence of fiber optic, a blind nasal intubation, retrograde intubation.
Have you done it?
No, sir.
Tell me what are the relative contraindications for retrograde as well as blind nasal? In this
Retrograde,
patient. I'm talking of this patient itself.
in this patient, contraindication for retrograde would be
Relative contraindication. I'm not saying absolute. Relative. And that was the reason why I asked for the MRI, so as to know the extent of the lesion in the base of the tongue. Because even if I'm going in the retrograde or I'm going blind nasal, I may hit the base of the tongue and I may dislodge the tumor or bleed the tumor. So that I have to keep a tab. Okay, that's the reason I said I will prefer to go for an MRI, which will tell me what exactly is the extent of the lesion. Okay, extent is not there. Fine. Now tell me steps for retrograde.
Steps for retrograde intubation. You enter through the cricothyroid membrane. You can put a guide wire, which you can put a long guide wire, a PCNL guide wire, or
Wait, how are you going to enter the cricothyroid membrane? How?
through the neck. Through the neck, sir. You can put a 2He. You can put a 2He needle with the face. A 2He needle with.
Yes,
Yes, sir. You can enter the cricothyroid membrane with the 2He needle with the facet facing upwards, so that the guide wire goes up and not down. And then through the 2He needle, you can thread in a long, strong guide wire like a PCNL guide wire or any vascular surgery guide wires. And if it comes out through the nose or the mouth.
It came out from the mouth. Next.
If it comes out through the mouth, since we want a nasal endotracheal intubation for this case, we can use a suction catheter through the nose and take it out through the nose, the guide wire.
How you're going to take it out?
You put a red rubber suction catheter into the nose and bring it out through the mouth. And then you attach the guide wire and this.
How the patient is going to bring out, or you are going to bring out the catheter? And how?
The nasal catheter, sir, or the guide wire?
Nasal catheter. I said your guide wire has come out of the mouth. Suddenly you become dark.
How do you bring out your catheter through the mouth? Nasal catheter through the mouth.
Yes, sir.
How do you take it out?
You take it out with a Magel's forceps.
Okay.
How you view it, madam? It has got only 1 centimeter mouth opening. How you view it?
You can ask the patient to bring it out, sir.
Patient's tongue is not protruding out. You only said that. So his tongue is not coming out. He's not unable to get out the catheter also then.
You can use the suction force to bring out.
No, dear. No. Okay, you brought out. Next. That I'll explain to you later.
Okay,
You brought out the catheter from the mouth. Next, what you do? Now
Railroad.
Railroad how?
Lubricate the endotracheal tube and railroad the tube on the guide wire and bring it out through the.
No, what I'm asking you, are you going to do a push through or a pull through method? There are different techniques of retrograde intubation. Pull through is more successful than push through. Now, what exactly is the difference between these two?
I don't know, sir.
Fair enough. What about the blind nasal intubation?
Blind nasal intubation after adequate topicalization of the airway, you introduce the endotracheal tube through the nose and you're guided either by the sound of the breath.
Listen,
or
see, when you are okay, continue. Yeah.
You can guide. You have to give an anti-silagogue first before you attempt all this. You can give an anti-silagogue to clear out the secretions, and then you pass the endotracheal.
Is there any other action for anti-silagogue when you are using topicalization? When you are topicalizing the airway? It reduces the mucosa. Mucus. Okay, so there will be better contact with the mucosa. The Lupin acid will have better contact with the mucosa. Okay. Continue.
Okay, sir. Yeah. So you after lubricated endotracheal tube is passed through the nose and you directed towards the airway and you're guided by the breath sounds. And a successful endotracheal intubation, either you're guided by the breath sounds or you can also use capnometry. A squaring of the EtCO2 waves are also indicative that you're going in the direction of the airway.
In the present days, capnometry will be more preferred because of the COVID. So
yes,
if your patient is COVID positive, then you cannot feel that breath sounds. It's better to go with a capnograph.
Capnometry. You can follow the capnometry, and if you're constantly hitting the anterior wall of the, if you're constantly going into the esophagus, maybe you can extend the head, extend the neck, extend the head at the AO joint so that the larynx becomes more posterior and it is in line with the tube. And if you're constantly hitting the anterior wall of the larynx, maybe you can flex the neck a little bit so that it is more in line. You can try external laryngeal manipulation also.
Okay, and, done. Fair enough. Okay. Done. Everything is done now. Come back to the original one. Your mouth opening is better and you want to intubate. Which tube you will use? Which endotracheal tube you prefer? Nasal only, but which?
A north-facing ring Aldear Elvin tube. Ring Adair Elvin tube.
Don't say north-facing, North Pole.
North Pole ring.
It's not for north-facing. It is North Pole.
Sorry, sir.
Okay. It will be North Pole. Okay. That is better for a surgeon. Yes, next. Sir. Now this patient, if he's going to go with your free flap, the surgeon may ask, suppose tracheostomy is to be done then.
Yes, sir.
Okay, if patient is shifted with a North Pole, let me say, because it's a free flap done, maybe the surgery lasted for 10, 11, 12 hours. So I don't want to reverse and extubate the patient. Anyway, it is difficult to re-intubate even after the extubation is being done. So I'll better wait for the patient to become completely conscious.
Okay, sir.
In that condition, I'll prefer to keep the tube overnight. Will you shift the patient with a North Pole? You are intubated with a North Pole.
Okay, sir.
Tell me.
the problem with sending the patient with a ring Adair-Elvin tube, RA tube, is that suctioning and toileting of the trachea is more difficult with
That's exactly what I'm asking you. So how will you do?
preformed tubes.
Now, how you're going to shift the patient? I'm a surgeon. I said, madam, sorry, I took 12 hours. Patient has become completely chilled. So I cannot reverse the patient. And moreover, I'm afraid and rather 100% sure you will not be able to re-intubate the patient with a free flap done and so many other things done. So I'll prefer to ventilate the patient, or maybe I don't mind shifting on a T-piece also in the recovery. So how you are going to shift with your north pole, because you intubated with the north pole?
So my worry would be an endotracheal suction would be difficult with that tube. So one.
Yes, dear, how you are going to take over?
Retain the tube or change the tube? That's what sir is asking.
Sorry?
Sir?
Will you retain the North Pole tube or are you going to change it?
No, she has put the north pole already.
Okay.
She said she has put the north pole tube. Next.
I can change the. I can put in a bougie.
How you can put a bougie? It is a right angle, this tube. You see, it is difficult to put a suction. What about your bougie? Bougie is more rigid than your suction. Anu, are you listening me?
I am listening, sir, but I'm not.
I'll give you one hint, dear. Just listen to me. Have you used North Pole tubes?
Yes, sir. Of course, sir.
In your institute, are you using North Pole tubes?
Yes, sir.
If you have seen the North Pole tubes, I don't know whether you can see my hand. It's very diagrammatic. Can you see my finger? North Pole.
I cannot see your video, sir.
How can I come on the front page?
Yes.
I don't know.
Yes, sir. I can see you now.
Now you can see? You can see my finger?
Yes, sir.
No.
Yes, sir, I can.
I don't know how. Binil, can you bring me on the front page?
I can see you, sir.
Wait, let Binil bring me on the front page.
So you are clearly visible, sir. The
I'm
full image,
visible.
fingers, everything is visible.
See, now you are more visible than me. Bring me at your place.
Now she can just select it, your image.
I don't know how to do that.
Okay, well, Binil will see that. I will direct it. Right.
Sir, it's visible.
See, everybody visible except me. Anyway, just listen, Anu, for you. When this is your tube, I'm just drawing the north pole this angle only. I'm not drawing the endotracheal portion. If you just see the tube tomorrow, go in your OT, check the tube. At this angle, there is a Caesar mark. They have placed a Caesar mark here. The Caesar mark tells that you can cut the tube here if you want to shift the patient, so that the suctioning is easier thereafter. Even you can put a bougie also. And more importantly, the dimension of the tube, because the connector is here, your North Pole tube connection is here. But the connection from here to the angle, the dimension, the diameter is same. So I can put the same connector here. There is a Caesar mark at the angle. Just go and have a look.
Okay, sir.
Something new.
Right.
No, Anu? Something new? Heard?
Yes, sir. Usually the radial forearm flap patients get a tracheostomy post-op, sir.
But I said here, I don't want, I'm a surgeon, I have to do tracheostomy.
Okay, sir.
Next. So, tracheostomy, forget it. But I'm just telling you, if at all, forget if it is not tracheostomy. Let me tell you, if it is done PMMC flap. And now I want to shift the patient overnight on the tube because of the safety of the patient. And you have put a North Pole. So you should be able to tell in the exam that there is a Caesar mark. Tomorrow, go and see the Caesar mark there. So you can cut the tube there. Okay?
Okay.
This is the answer I expect from you.
Okay.
Don't worry, it's not your fault. I have asked this almost at 40, 50 times. Nobody has told this. So don't get upset and depressed. Don't worry. Okay. another thing that is been important, because there are some incidences that have been happened whereby a tracheostomy tube, I mean, initially what they do when they are doing this, they tell, I will do tracheostomy. So you remove your tube and you put an armor tube. So if you put an armor tube, and there are 3 incidences that happened when the armor tube is to be replaced with a tracheostomy tube, the carotid was hurt and the patient bled so much that everybody failed to put the both tracheostomy as well as orotracheal tube, and patient died on table. So it is wiser to put straight away the tracheostomy tube with a sterile adapter so that it is safer from the patient point of view. Okay.
Okay.
Sunil, you want to ask something, Rajan?
Yeah, no, suppose this patient in the post-op period who wasn't tracheostomized came with a rebleed, with a profuse bleeding from the flap site. He
Yes.
doesn't have a tracheostomy. How do you manage the case?
After extubation, sir?
Yeah.
Not tracheostomized. Patient is tracheostomized, you said.
No, sir. Not tracheostomized.
Okay, I'm sorry. I didn't hear that. Okay.
Yeah. Okay, patient is not tracheostomized. After 2 days post-op, patient developed bleeding, severe bleeding from the flap site, intraoral bleeding. And they want to do a re-exploration and control the bleeding.
Good.
Will secure the airway.
Okay, sir. So if it is an active, if the patient is giving, if the clinical scenario is such that it is a history of bleeding, if it's a controlled bleeding, like when I'm seeing the patient, there is no active bleeding at that point, and if I think that in my vision, no, I think the safest would be to do a tracheostomy under local anesthesia, because if I attempt to do any laryngoscopy, be it with a CMAC, be it with a fiber optic, it can cause further trauma and further bleeding. I think the safest option would be to go for a tracheostomy under local anesthesia and secure the airway before re-exploring the flap
Do you
site.
think fiber optic intubation will be easier in this case?
The fiber optic in a recently operated
no, in a bleeding
situation.
Patient. In a bleeding patient. Actively bleeding patient. What about can you do fiber optic intubation?
You can, if you can suction out all the blood with a large bore suction, like a Yonkers, but fiber optic would just cause trauma and cause further.
Are you worried about trauma or your visibility?
My visibility, if it is not actively bleeding, then the process of fiber optic bronchoscopy would cause further trauma, bleeding, and obscuring the vision.
Active bleeding, it's not advisable. Okay. It's
okay.
Extremely
so
difficult
then,
to visualize.
There will be difficulty in visualization.
Yeah, your answer was right. Tracheostomy under local anesthesia will be the safest option. Okay. Then suppose this patient maybe after surgery comes for say a marginal mandibulectomy, something comes to you for some other surgery. So if you are investigating, will you do some other tests? Additional investigation we will ask for. So I'll just ask you what are the radiological tests which can help you to predict a difficult airway.
Radiological predictors of difficult airway from a chest X-ray, a lateral chest X-ray view, the gap between the occiput and the first vertebrae, if it is less than 5 millimeter, or the gap between C1 atlas and axis, the gap between occiput and C1 and the gap between C1 and C2, if it is less than 5 millimeter, it is a predictor of difficult airway. Second is if the posterior mandibular depth, which is a line drawn, which is the distance between the upper alveolar surface of the mandible behind the third molar. If you drop the distance from there to the lower border of the mandible is the posterior mandibular depth. If that is more than 2.5 centimeters, or if the ratio between the effective mandibular length and the posterior mandibular depth is less than 3.6. These are predictors from from a X-ray of difficult airway. Then you can also do an ultrasound of the neck to see if there are any soft tissue swellings. You can do a sublingual ultrasound. In the sublingual ultrasound, if you can see the epiglottis, if you cannot visualize the arytenoids or the epiglottis, those are also predictors of difficult airway.
When you were talking about applying nasal intubation,
Sir.
you told you will go by the square ETC2 waveform or by the breath sounds. Is there any other method by which you can say that you are going towards the larynx? Has settled during this COVID time? Any safer techniques? Anything else?
Capnometry?
Yeah,
Don't know.
you already told. So you can attach a Jackson-Lee circuit and with a low flow of oxygen, you can look for the back movement. As you go towards the glottic opening, the back movement will be better. As you go away from the glottic opening, it will be lesser. It will be more, this time it will be more hygienic,
Yes.
safer. Okay.
Yes.
I think they should be enough for us. Anybody, anything else? I think there are some questions from the audience. We'll have to find out that also, because I just read one question that in the retrograde intubation, how you're going to put the catheter into the, how the suction catheter will help in the oral cavity. I think that's what is very important to know, that once the the guide wire has come out from the mouth and then suction catheter, how it is to be brought out. What she could not tell is what we used to do there when the mouth opening is just 1 centimeter, where I can put only Magill's forceps instead of laryngoscope, because laryngoscope blade, because the flange is quite big. So in such condition, what I do is I just put the OT lamp on the top, and then I put a tongue depressor. Tongue depressor is absolutely thin, and from the tongue depressor, I just see the color of the catheter and I pull it out. And once it is pulled out, then I can railroad the guide wire into the catheter, and thereafter I can bring it out the wire through the nose, and thereafter, as you rightly said, we can just push the guide tube across the guide wire. That's the way we can do. There's a question somebody asked. I'm not sure who was that. Anybody else has got any questions? I can't make out.
There is no more questions pertaining to this case discussion.
Fine. Thank you.
We'll ask comments from other faculties.
Yes, any comment?
Dr. Rakesh is there. Dr. Shamshad
Rakesh.
Begum.
Venkatgiri is also there, and Nazar is also there.
Yes.
Yes, Rakesh.
When you are there, I have no comments. You are the boss.
Who's saying this? Who's saying this?
Huh? You are the boss.
Thank you. Thank you, boss.
That was a really an extensive discussion. A lot of practical tips we got. Really beneficial, even for us.
Thank you. Thank you so much. Rakesh?
I think Dr. Rakesh left.
Rakesh left.
Binil.
Yeah, we appreciate the presence of Dr. Baburaj.
Yeah, Dr. Baburaj. He was a faculty for a previous presentation. Dr. Baburaj and Dr. Shamshad is there.
Shamshad Begum, madam, you want to say something? Madam was there.
No.
Anyway, Anu, it was a good performance by you. I will not say no. It was a good performance.
Sir, if it is a good performance, we should present a certificate here. So yes. I will just share the certificate now.
She deserves.
Thank you, sir.
But I'm afraid, I'm sure you have learned something more.
Definitely, sir. Definitely. Sir. Thank you very much, sir.
Thank you, Nazar. Thank you, Venkat. Binil.
So I request Gedu sir to give the certificate to Dr. Anu. I hope it's visible or it's not visible.
It's coming. It's coming. It has not come. It's coming.
Oh,
let it come. Let it come.
Something happened.
Thank you, Dr. Sunil Rajan and Dr. Gadu for
Thank you.
chairing the session, PG session.
I hope you are all happy.
Enjoyed it.
Excellent.
And thank you for inviting me. I already told I love Kerala because they are the truly academic people. And Nazar said it's a greenery, but more than greenery, it is academic, which I love.
Sir, I still remember one incident which you mentioned at Tata when I came there for a conference. I can see the entire greenery of Mumbai city through a window from the hotel where I stayed at Perindalmanna. I still remember that words.
Yes, I definitely say that. I will never forget Perindalmanna. I will never forget. That was my first meeting with you.
I remember you were working there in that district. Still, I remember that.
Anu, your certificate is ready.
Once situation improves, please make a trip to our place as our guest.
Always, no problem.
Yes,
I always love to be in Kerala, and I love always Kerala to be with me. Don't worry.
Okay.
So this is the certificate.
Anu, this is your certificate now. Okay.
PG resident from Amrita Institute of Medical Sciences, Cochin. And congratulations to Dr. Anu. Her ISN number is A3478-A. Congratulations. And I also just want to mention our next program, which will be held on next Saturday. The topic will be neuro-operative strategies in spinal and intracranial surgeries by Dr. Zulfikar Ali from Jammu Kashmir.
Yes.
And the second topic will be a case discussion on scoliosis correction from Government Medical College, Trivandrum. And our examiners will be Dr. Raghavendra Pai from Bangalore and Dr. Baburaj C from Government Medical College, Trivandrum. So I request our PG students to attend both the sessions.
I think it's a very good case.
There is another session, another academic program from ISA Kerala State Chapter, which will be held on next Thursday by our own president, Dr. E.K. Abdul Nasser. He is a specialist in regional anesthesia. So he will be talking on truncal blocks in clinical practice. So request all the members to join this program also.
Nasser has really become a boss now. As far as pain is concerned, I still remember him.
Yeah, sir. I'm happy to hear that.
But congrats, I'm proud of you.
And yes. I thank today's speakers. Today, actually, we had 4 speakers, 4 faculties. Dr. Rakesh Garg from All India Institute of Medical Sciences, and Dr. Sudhish Kannan from Government Medical College, Bangalore, and Dr. Sunil Rajan from Amrita Institute of Medical Sciences, and our favorite Gedu sir from Navi Mumbai.
Thank you so much for all of you for inviting me. I'm proud to be a part of it, even today, tomorrow, any day. Don't worry.
And I thank today's presenter, Dr. Anu Abraham, for her excellent performance. And I thank all the participants for joining us today evening.
Anu,
anything else, over to Nasser sir for concluding remarks.
That was a wonderful session with a lot of practical tips, not only for the postgraduate, but for us.